All right, thank you guys for joining us this morning. My name is Sebla Barak, and I will be your MC for this morning. Thank you for having me, TSU. We have a pretty packed agenda, and we're going to try to stick to time. So I will be running through this effectively. So everybody should have received a pamphlet where you'll have the bios of all our speakers and our panelists. So as we introduce everybody, you're more than welcome to read their bios. We won't be doing it up front. So like I said, welcome this morning, and we're here to talk and do a deep dive into prostate cancer. So first, our first speaker of the day, I'd like to bring up Dr. Grace Loud.
Good morning. Thank you all so very much for being here this morning. Just want to give a big thank you to the study team led by Dr. Veronica Ajewole, to our representatives from our upper administration, Houston Methodist team, also members of the advisory committee and the work group. Thank you all so very much. And now we're going to go ahead and move to our next speaker, who's going to be VP Penn Marshall, the VP of Innovation and Research here at Texas Southern University. So I'll just go ahead and read her bio here. Dr. Penn Marshall earned her BS in biology and MS in biology with a concentration in environmental science from Hampton University. She received her PhD in community nutrition from Virginia Tech in Blacksburg, Virginia. She has a proven track record of collaboration and a commitment to research and innovation, most significantly in the STEM-focused disciplines. Her experience as both an administrator and faculty member gives her excellent perspective for her role here at Texas Southern University. She's been successful in all aspects of research and innovation, securing and expanding external funding, partnering with top-tier funding agencies, and enhancing the efficiency and effectiveness of the research process. And she's been an ardent supporter of our study. So Dr. Penn Marshall, if you will please come up for opening remarks. Thank you.
Good morning again, everyone, and thank you so much, Dr. Loud. It is indeed my pleasure to be here, and on behalf of our 13th president, President Licia Crumpton-Young, to welcome each of you virtually and in person to Tiger Nation. So welcome. At Texas Southern University, we are all committed, faculty, students, staff members, alumni, to three guiding principles of innovation, transformation, and disruption. And we do these three things while seizing the opportunities that will shape our future and the future of our communities. So it is my pleasure to be here today. We are going to disrupt the prostate cancer statistics. The prostate cancer statistics, 1 in 8 Black men will be diagnosed with prostate cancer, and that is unnecessary. If we as women, as partners, as sisters, as friends, and neighbors would take men to the doctor, ensure that they're screened for prostate cancer, then these statistics will change drastically. So I really do admonish and thank Dr. Ajewole, thank Dr. Loud, thank the whole team because of the things that they are doing in the community, in the university, and training the next generation of students. They have a heart for this. I thank all of the panelists, virtually all of the panelists who are here, because it's going to take a partnership. It's going to take collaboration to make a difference in the lives of others. So thank you and welcome again.
All right, good morning again, everyone. And it is our ultimate pleasure to welcome you again to today's conference. We are very excited that you all have, shared a portion of your morning with us this beautiful Saturday. My name is Veronica Ajewole, and I have the privilege of being the principal investigator and the director for this program. And, I cannot start talking about the study without first acknowledging everyone that contributed this study. I want to say thank you to Dr. Loud, our co-PI. Thank you, Dr. Loud. We appreciate you. We also have another co-PI, Dr. Uche Ndefo, who is not able to join us today because of other obligations, but we are very grateful. Big thank you to the team from Houston Methodist Hospital. Dr. Steve is here. Thank you so much. A big thank you to the community work group. Thank you, all of you, for coming. Big thank you to our community advisory group. Thank you to, Dr. Richard Asata. The bio for everybody that contributed to the study is in the booklets. Please, because of time, I won't be able to go through everybody's bio or list out the name of everyone, but I just want to make sure that you all know that I appreciate you. And for all the vendors, that took their time to engage this morning, thank you very much. To all our sponsors as well. And I see the Genentech team back there. Thank you for sponsoring our event. Thank you for the contribution. And we are very grateful. Before I go into the study, I want to acknowledge my husband. We've been married for 10 years, and he has been a great support system. Andrew, thank you very much. We are very grateful, and I appreciate everyone for joining us this morning. And to the team online, I appreciate you guys as well. So, I would like to do a quick throwback to how this whole journey began. For those of us in research, we are very familiar with what the RFA is called, right? That is the call out from any funding agency requesting us to submit a proposal. So if you look at the date on that RFA, it happened in mid-2020. And we all remember what happened, COVID. So we had this RFA, available to us right in the midst of COVID in lockdown. But myself, Dr. Ndefo, Dr. Loud, we rallied around each other. The kids were at home, homeschooling, and we did the best we could, and we successfully submitted the grant. That's the second picture over there. And then towards the end of August 2020, we received that great news, notice of grant award. And that is the picture right there. So, just kind of walking us through that entire process and saying that it's been a long journey, but we are glad that we were able to, successfully secure the funding, $250,000 for the works that we are doing here today. All right, so let us take a quick look at prostate cancer by the numbers. That is what we are here to talk about. So if we look at the bars, in the picture here, I want to point our attention to the orange bar. The orange bar is signifying African American community. And it is apparent that there is the numbers of African American that develop prostate cancer is higher compared to all the other races. And then on this other side, we see again, looking at the orange bar, comparing Black men to other men of other ethnicity, we see that that number is significantly higher. The second bar here is specific for, distant type of prostate cancer, which we consider to be an aggressive type of prostate cancer. So these are the things that makes us to ask that question, that why are we seeing this difference and what do we need to do differently? So this will take us to discussing briefly what is health disparity. Health disparity defined by CDC is saying that these are preventable differences. So if we look back on that graph, those differences that we see, are they preventable? And these preventable differences are noticed in the burden of disease, injury, violence, opportunities to achieve optimal health outcomes experienced by socially disadvantaged people. So that is the crux right there. Socially disadvantaged community tend to experience, these differences that we are seeing. Healthy People 2020 in the same vein defined health disparity as a particular type of health difference closely linked with, social or economically disadvantaged community. Again, we continue to ask ourselves this question as researchers to now talk a little bit about the social determinants of health, right? Because we are looking at socially or economically disadvantaged community. Healthy People 2020, which was what we used when we started the grants, has now transitioned into Healthy People 2030, as categorized the social determinants of health into 5 major contexts. One of them being healthcare. When we look at that, it says access and quality. So we are not just looking at access, what is the quality of care that people are receiving? Education, access and quality, economic stability, social and community context, as well as neighborhood and built environment. So the three previous slides that I showed were the questions that us in this research group, we try to intersect together to ask or answer that question. Why are we seeing this huge difference in incidence and mortality due to prostate cancer among African American population? So with that context in mind, we basically sat down and came up with two intentions for this study. The first one was for us to identify the key elements that are responsible for aggressive prostate cancer among African American population. Our second aim was then to develop a social determinant of health-based interventions through community-based participatory research. So you will see as we go along that we integrated a lot of community participation in this study, and the intention is for us to potentially reduce the burden of aggressive prostate cancer among African American males. Like you can imagine, we did not work alone. It took a lot of collaborative effort. We worked closely with Houston Methodist Hospital, which is our hospital-based cancer registry. We worked closely in collaboration with Sankofa Research Institute and our community work group. We worked very closely with Community Advisory Board, as well as involvement of our PharmD students and interns during the course of this study. The variables included in this study, initially we set out to review data over a 10-year time frame, but because of some logistical challenges that we came into, we had to reduce the time frame to 2016 to 2021. Our population specifically was African American men that had prostate cancer in Houston Methodist Hospital Cancer Center. For those of us that are not familiar with Houston Methodist Cancer Center, it's located here in the Texas Medical Center area, but it has locations all across the Houston metropolitan area. Demographics included age, race, ethnicity, zip code, marital status, type of insurance, history of cancer, and any use of alcohol or tobacco. We also looked at prostate cancer specific information, looking at the stage of the disease. Is there anything that will predict the risk or the type of disease that the patient has? We also looked at comorbidities and medications that have been documented in literature to increase the incidence of prostate cancer. All right, more again into the our data collection plan. We basically started out from the Houston Methodist Cancer Registry because that was the anchor for us to be able to gather data related to our patient population. We did our review looking into the medical records, a lot of data analysis. Steve is here. He will talk a little bit about it when we have our panel discussion. And then we were able to link that information with something called area deprivation index. The area deprivation index is basically signifying the extent of disadvantage or economic advantage that the population has depending on their neighborhood. It gives a scoring system based on the zip code and the census tract. So that was what we used. We were able to integrate this and linked all this data with the social determinant of health domains. Okay, so study timeline. Again, we've been on this journey for over 2 years. Started out in 2020, IRB approval, all the credentialing, contracting and everything that needed to happen. In 2021, September, we started engaging with the community members, Community Advisory Board. 2022, September, recently, we closed out finalizing the findings of our study. And we are here today, November 5th, to disseminate and share with the community the findings from this study. Okay, and that is, introducing us to the study. And I would like to bring up stage our MC to bring up the keynote speaker. Thank you very much.
Thank you. Okay, so next, our first keynote speaker, let me introduce to you Dr. Curtis Pettaway, and he'll be joining us online.
Hi, can everybody hear me?
Yes, you can.
Well, it's a real pleasure to be here with you today. I had planned to be there, but unfortunate circumstances changed things at the last minute. I certainly want to congratulate our colleagues at Texas Southern University. Veronica's done a wonderful job putting this together. And so what I'll do today is I'm going to talk about detection and treatment among prostate cancer in African-American men. Specifically, what's the problem? And so what we're going to do, first of all, since many of the audience members may not be health professionals, we'll talk a little bit about the male pelvic anatomy and the location of the prostate, just to get everybody on the same page. So this is a diagram of the male pelvic anatomy, and this is the prostate here. It's a walnut-shaped organ that sits beneath the bladder and in front of the rectum. The urine stream coming from the bladder goes directly through the prostate and out through the urethra here. The prostate is strategically positioned such that if you wanted to examine the prostate, you can do it indirectly by putting a gloved finger in the rectum and then feeling the prostate directly in front of the rectum. Now, the prostate is strategically located in that if it's beneath the bladder, anything that causes prostatic enlargement can squeeze off the urinary stream, producing symptoms of decreased ability to urinate. If that urine builds up, it can become laden with bacteria. One can develop an infection, so one can have burning, fever. If the prostate irritates the base of the bladder can become irritated and one can develop frequent urination. The prostate can also be a source of pelvic pain, pain beneath the testicles, or pain in the back or the area above the pubic bone. Three processes that, as urologists, we commonly see. One is inflammation of the prostate, which can occur by bacteria or other non-bacterial causes. It causes the prostate to swell. And again, it can produce those symptoms that we just talked about. The other thing we often treat is benign growth of the prostate, which usually occurs also centrally within the prostate. Again, it can begin to choke off the urinary stream, irritate the bladder, and produce some of the symptoms that I had talked about before. The other process, of course, which we're going to focus on today is prostate cancer. Now, the important thing to recognize about prostate cancer is that most men today don't have any symptoms when they're diagnosed with prostate cancer. So prostate cancer can be a silent process. And this is the unrestrained growth of cancer cells that can not only grow locally, but can spread to regional lymph nodes, bony sites, or other visceral organs. And certainly it can become the death of patients. So today, we're going to talk about recent incidence and mortality. We're going to talk about the broader concept of mortality among men of African descent. And this is important because it's not just African Americans, it's men of African descent. Talk about the contributions. We'll talk a little bit more about health care equity and quality of care that potentially play a role in this increased mortality. We'll talk about things that you may not be aware of, disparities in management and outcome of prostate cancer amongst the spectrum of men with localized prostate cancer. We'll talk a little bit about the promise of precision medicine. This field is becoming very exciting with new advances. And the question will be, will Black men get to reap the benefits of these technological advances? So with that in mind, Veronica talked a little bit about the incidence of prostate cancer. Certainly, it is the most common cancer among males over the age of 50, and the second most common cause of cancer death. Lifetime risk of prostate cancer is about 13%, or 1 in 8. And it's estimated that over 3 million men are living today with prostate cancer. As Veronica stated, there's a tremendous difference in the incidence and mortality of prostate cancer. When we look at the incidence of prostate cancer among Black men, it's 60 to 70% higher than other racial and ethnic groups. The disturbing thing is that even in 2022, the mortality, the death, the rate of death from prostate cancer is twofold higher, and that's really disturbing. This slide shows us some information on prostate cancer stratified by age and also racial and ethnic groups. And we see that prostate cancer incidence increases with age. So this is a disease process affecting elderly men. And when we look at Black men in the purple line, we see an interesting thing that may point us to some biology. We see that the uptick in prostate cancer among African men occurs about 5 years earlier than the uptick in other racial and ethnic groups. So the age of onset of clinically defined prostate cancer is about 5 years earlier in Black men than in other racial and ethnic groups. And again, this may point to a biological difference in prostate cancer behavior. Now, again, we look at mortality. We see that mortality also increases with age. The median age of prostate cancer death is about 80. But what do we see for the African-American population? The uptick in mortality from prostate cancer also occurs earlier. So this really speaks to differences that must be addressed if we're ever going to decrease prostate cancer mortality among African-American men, or among Black men, I should say. Now, the reason to broaden this is because when we look at the worldwide incidence and mortality of prostate cancer, and this is specifically looking at worldwide mortality, and the darker the orange color, the higher the mortality. And where do we see the highest rates? South Africa, the Caribbean, West African nations. And we see that all of these men share African ancestry. So this is a problem not only affecting African Americans, it's really men of African descent. And the question is why? And when we look at the literature, there are a multitude of reasons that we can place into different groups. Healthcare access, which is important. Patient and physician or institutional biases in management. You wouldn't think that might be a cause, but it is. Also, intrinsic disease biology. All of these factors play a role in the increased mortality from prostate cancer. Now, Dr. Ajewole talked about healthcare, care and talked about Healthy People 2030. Well, in 2010, the goal for and the intent of our national intent with respect to attacking disparities was elucidated in Healthy People 2020, where it said we want to achieve healthcare equity, eliminate disparities, and improve the health of all groups. So what is health equity? And I like this definition by Robert Wood Johnson. It said healthcare equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, their consequences, including powerlessness, lack of access to good jobs with fair pay, quality education, housing, safe environments, and health care. So this is the definition of what we're trying to achieve with health equity. And when we talk about quality of care, there are 6 domains that are recognized by the National Academy of Medicine. Healthcare should be safe. Healthcare should be effective, using the most effective treatments. Healthcare should be patient-centered, providing care that is respectful and responsible to individual patient preferences. Healthcare should be timely, reducing waits and harmful delays. Healthcare should be efficient, and healthcare should be equitable, using the definition that we just taught. So this is what quality healthcare really means. Now, when we talk about prostate cancer, how do we diagnose it? There are at least 4 tools that we use. Prostate-specific antigen is a blood test produced by prostate cells. It's not prostate-specific. It's prostate-specific, but not cancer-specific. PSA is an enzyme that's used, produced by the body that helps liquefy semen. Historically, its value was thought to be, a normal level was thought to be less than 4 nanogram per deciliter. This is a number that many have heard. But we know, more importantly, it's more critical to look at what the baseline PSA is, especially at a young age, and look at PSA changes over time. This gives us important insights into what is going on in the prostate and whether cancer may be present or not. The other thing we use is digital rectal exam. Now, digital rectal exam we know is insensitive because many men have a normal digital rectal exam and may have an elevated PSA and be diagnosed with prostate cancer. But there are some men who have normal PSA levels and the digital rectal exam is abnormal. And so this can help us detect that smaller group of men. It also can give us insights into colorectal cancer as well. The way we diagnose prostate cancer is that we need to get tissue, and that's done by prostate biopsy. And this is often done because the PSA is elevated or the rectal exam is normal. And it's usually guided by transrectal ultrasound guidance. It allows us to guide the needle. More recently, a imaging test called magnetic resonance imaging, or MRI, has really revolutionized how we diagnose prostate cancer and how we target prostate cancer. You can see kind of a darkened lesion here in the anterior aspect of the prostate. And this is a lesion that may not have been detected in any way because the rectal exam likely would have been normal, but you see an anteriorly located lesion which would not have been felt. PSA may have been elevated and allows us to target the biopsy. So when we look at prostate cancer in Black men, what do we see? We see early or disease onset. I'm going to show you data about increasing tumor volumes in men of African descent. We see earlier, historically, that Black men had an increased incidence of metastasis at presentation. When we look at the literature, we can see at the DNA, the RNA, and the protein level, there are correlates of aggressive prostate cancer that you see in African-American men that you don't see in age and stage matched Caucasian men. And so for all of these reasons, early detection of prostate cancer makes sense among African-American men. We know that early can save lives. Well, this is one study that looks at long-term outcomes. This is part of the European randomized trial. This is the Swiss cohort of that. And they compared a group of men who were invited into a screening program or control men who were not invited into the screening program. And then again, about 10,000 men were invited to be screened. 10,000 men were invited into the control group. And the men in the screening cohort got PSA testing every 2 years and got a biopsy for an elevated PSA or other indications. The men in the control group were not offered PSA screening, but over time, many of those men did get PSA testing. So this didn't really become, at the end, a trial of screening versus no screening. It became a trial of planned screening versus more opportunistic screening. And so what we see here is what you might expect. In the men that were screened, they would have a higher incidence of prostate cancer over time compared to the control group. But the important question is, did that save lives? And the answer is yes, it did. When we look at the number of deaths in the control group, higher than in the screening group, the relative reduction in mortality was 29%, and correlates of increased prostate cancer death were men that weren't tested, men that joined the program later, or men that had longer follow-up. And the longer your follow-up, the more opportunity you have to die from prostate cancer. What do we know about African-American men in clinical trials? This has really been a missed opportunity. In the 2 large trials, the PLCO trial and the European randomized, the ERSPC trial, there were few men of African descent. So we don't have this data, the highest level 1 data, we call it, from randomized controlled trials. What we do have is some population-based data, and we can look at the SEER data, which is a population-based cancer registry, and ask what has happened with prostate cancer among various populations over time. And we see that within the PSA era, prostate cancer mortality has decreased consistently by about 4% per year. And in fact, the rate of decline in the PSA era has been greater than that in the Caucasian population. This is translated to, in more recent years, when you look at 5-year type of data, stage of prostate cancer, which used to be higher in African-American men at presentation, is becoming very similar, fortunately, to the Caucasian population. You also see 5-year survival data looking very similar. And this is, again, survival at 5 years. This is not overall mortality, so it's a different denominator. But this is somewhat in jeopardy, or at least has been somewhat in jeopardy over time, because in 2012, the United States Preventive Services Task Force came out with a recommendation against prostate cancer screening. And this slide looks at what happened with respect to prostate cancer diagnosis and stage of diagnosis over time after this recommendation. And you can see it importantly stratified by race. And the Black men are in the blue curve. And what you see is that after this recommendation occurred, primary care physicians began to really decrease their use of PSA. And you can see that among all racial and ethnic groups, the diagnosis of prostate cancer decreased. Now, some might say, well, this is a good thing because many cancers are indolent that are diagnosed. Well, let's look at the types of cancers that were diagnosed during that time. True, there was a decrease in the incidence of localized cancer. Regional cancers decreased a little bit, but dangerously, the incidence of distant cancers, or the cancers that are not curable or very difficult to cure, in essence, in many cases not curable, increased after we stopped using PSA as an early detection strategy. So this is a warning. Furthermore, when we look at the mortality to incidence ratio, so what you do here is you divide the mortality data by the incidence data, and you get a ratio of men who are dying versus those who have been diagnosed. You see that amongst US Black men, the mortality to incidence ratio is higher for Black versus white men. We know this. But what about countries such as those in the Caribbean who may not have the resources for widespread PSA testing and treatment? The mortality to incidence ratio among these Black men is much higher even. So clearly there is data that PSA does make a difference. And importantly, our updated recommendations do call for a more systematic approach to screening, starting off with taking a good history, physical exam, finding about family history of cancer, prostate cancers, whether there's any germline mutations in an individual, what their racial and ethnic group is. And that then stratifies men for starting a discussion about the risks and benefits for treatment. For the average risk patient, starting at about the age of 45, having that discussion about getting a PSA test. For those who are in higher risk group, African Americans or those with germline mutations, starting the discussion at age 40 and then getting a baseline PSA. Now we know if PSA is less than 1, that is a good prognostic feature, and you may not have to get testing every year. In fact, it's recommended that you get it maybe every 2 to 4 years, where if your PSA is 3 or higher, this is going to prompt further evaluation. Now, what about the spectrum of prostate cancer? When we look across the spectrum of prostate cancer, there are a group of men who are diagnosed that have very favorable features, at least by the things we look at today: PSA, clinical stage, rectal examination findings. And the National Comprehensive Cancer Group basically divides them into various risk groups. And so for men in the low and very low risk group, defined by very small cancers, low Gleason scores or grade groupings, PSAs less than 10, we know that many of these men may not need immediate treatment, and their treatment can be delayed for several years, and they may not need any treatment at all. And so the preferred management for these men is active surveillance. And the question becomes, when you look at this, the predilection, now, when you think about cancer, you might say, man, would I ever observe a cancer? Well, this is predicated on several beliefs. One, that the existing cancer is clinically insignificant, that the progression of the disease will be slow, and we will be able to capture that progression in our follow-up efforts. And then when we intervene, that patient would be just as curable then as if we had treated him earlier. Now, we know that this is safe and effective among Caucasian population because it spares or delays the morbidity of treatment. Now, what about African Americans? We know that there are differences. And when you look at a population of men in this study who would have been candidates for active surveillance, these are African American men versus white men who didn't choose to undergo surveillance. They said, well, no, I want to have treatment. I want to have surgery. What did we find? We found that the African American men had higher tumor volumes in their prostatectomy specimens. We also know that the distribution of tumors was different. African American men had more tumors in the anterior aspect of the prostate that may not have been diagnosed or sampled by the biopsy. And this was certainly true in those men who had upgrading of their cancers. And often these cancers would only be diagnosed by MRI. And we know that there is a disparity in the use of MRI among African American men. Now, this is one nice study that did include men of African descent. This is from the French territorial island of Guadeloupe in the Caribbean. And 95% of this population is from West Africa. So there were 234 patients. They used common active surveillance criteria, men in the very low and low risk group. They did have some men with favorable intermediate risk group, but that was a minority. They did the study very well. They performed confirmatory biopsies at 12 months. 62% of the men did have MRIs, and they looked at surveillance biopsies at 2 and 4 years. And so they asked the question, how did this group do? This group did very well. You can see the cancer-specific survival here with relatively short follow-up was excellent. Only 4 men died, and there were no prostate cancer diagnosis. 1 man had metastatic disease at pelvic lymph node dissection. So these data look very encouraging for active surveillance among men of African descent who had low-risk prostate cancer. But when we actually look at the progression of disease over time, not death, but the men that actually progressed over time and came off active surveillance, we could see that by 5 years, about 50% of the men had progressed and were off active surveillance. By 10 years, 60% of the men had progressed and were off active surveillance. Well, how does that compare to a Caucasian cohort? We look at 2 Caucasian cohorts at 5 years. 63% of the men are still on active surveillance. So it suggests that there are higher progression rates on active surveillance for men of African descent. And indeed, when you look at the reasons why men terminated active surveillance, it was because of tumor volume increase, grade progression, or shorter PSA doubling times. So this suggests that active surveillance may be feasible, but you have to watch Black men who are on active surveillance very carefully. Now, so when we look at, is it safe, yes or no? Well, we know that men who have a high rate of comorbidities, other disease processes, yes, active surveillance is safe. The PIVOT trial showed us this. But among men who are very healthy, it seems to be feasible in the low and the very low risk group, but we need to way to systematically make it more safe. Early confirmative biopsies that were done in this study, make sure MRIs are done to make sure you're detecting all disease. and making sure you're having an informed discussion with patients, letting them know that in available data, about 50% of men will have treatment within about 5 years. And you have to be committed to follow-up and confirmatory and interval biopsies. A study in community practice, 2 studies have shown that only 13 to 30% of physicians and patients are compliant with guideline-based follow-up. Again, so among the African-American population, this could even be more dangerous. What do we need to make this safer? We need to develop and maintain registries of men of African descent. And this is certainly something that is possible, being done by the Music Registry in Detroit. The American Urological Association has their Aqua Registry, but these are not specifically focused on African-American males. I'm a part of a group called the Consortium on Disparities in Urologic Conditions Conduct. We are just now launching a registry primarily looking at accruing men of African descent to a nationwide registry of prostate cancer patients. And I'll tell you a little bit more about our upcoming conference. We need to define practice protocols, best selection criteria, best criteria for confirmatory testing. What surveillance strategy should we be used? We need to be collecting tissue and blood on these patients to get tissue correlates of aggressive disease. We do have some biomarkers now that we can use that may be helpful among the African-American cohort, Decipher, Oncotype DX, and the Polaris test. These are good news. They are available. The bad news is that they're not widely available among the uninsured. And so this is a disparity. This is something that relates to health equity that we need to basically address. Now, what about men who have more significant disease? The intermediate or high-risk groups. These men have Gleason score 7 or higher cancers. They have more palpable tumors. Their PSA tests are higher. And so in general, these men are favored to undergo treatment with either prostatectomy or radiation-based treatment. And so it is accepted that these men should be treated. Now, what do we look at here when we see are men of African descent being treated in equal proportions as their Caucasian cohorts? And unfortunately, the answer is somewhat surprising. When we look at the National Cancer Database, a collaboration between the American Cancer Society and other groups, we see large data available. Over 200,000 white men, over 50, almost 60,000 Black men with intermediate to high-risk cancer, again, should be treated. They looked at a variety of correlates, including the age, year of diagnosis, insurance type, clinical factors. The endpoint of their study was receipt of definitive therapy within 6 months. So they're asking, were these men treated within 6 months? And the answer was, among the Caucasian population, average about 83% of those men were treated within 6 months. But for African-American men, it was lower, 74%. So that means almost a quarter of African-American men are not receiving prompt treatment within 6 months. Now, one of the things they also did is they looked at the facility data, the data that looks at men treated at different types of facilities. They could have been academic facilities, private practice facilities. They looked at regions of the country. And this line shows of 0 means that there was no preference in treatment, one group versus the other. Where you see this line going this way, it favors the Caucasian group being treated more. Where you see it going this way, it means it favors the African-American group being treated more preferentially. And what did they find? 39% of facilities favored treatment of Caucasians over Black men. This occurred in the South Central area, the South Atlantic regions. Academic centers were not immune to this. Younger age patients were often more treated, were favored white versus Black men. High-grade cancers often favored white versus Black men, which makes no sense because these are just the types of cancers that need treatment. So we have a disparity here. Another study looking at SEER data. Now, SEER data is another large population-based data that samples about 30% of the population. And so they asked a very similar question. They asked about treatment preferences among men with high-risk disease. Now, this is, again, high-risk disease that's hard to cure. And if you don't treat these patients, many of these men will die of their disease. Again, 80,000 white patients, about 17,000 Black patients, high-risk features. They correlated this with census tract data to correlate income data. And they asked the question about receipt of definitive therapy and what factors may be involved in this. And also, does this correlate with a death outcome? And what they found here, again, receipt of definitive therapy among the African-American population, 19% received no definitive therapy versus only 12% for the Caucasian population. Now, in this slide, what they have done is they've correlated race with financial status and also with receipt of definitive therapy. So here you have the lower income African-Americans and whites. You have the higher income African-Americans and whites. And the question is, who got treated? Well, the group that really got treated was the non-Hispanic high-income whites. Almost 90% got treated. On the other end of the spectrum, the lower income Blacks, only about 76% of that group got treated. When you even compare low-income Blacks to low-income whites, again, the low-income whites were treated more than the low-income Blacks. When you look at receipt, no definitive therapy at all, the low-income Blacks, almost a quarter of them received no therapy. In terms of type of treatment, lower-income Blacks were less often offered surgery compared to the higher income individuals and certainly the higher income whites. So we see some stark differences in treatment. And did this correlate with a mortality income? Which group had the highest mortality? It was the lower income Black men. This is striking. What about quality of care? This is a nice study out of Nashville that looked at healthcare cost and utilization amongst non-federal hospitals. And they looked at quality indicators such as surgeon and hospital volume, blood transfusions, complications, length of stay, and in-hospital mortality. And they looked at this for white and Black men. And what you see here are quartiles of groups. And so the four would represent the highest income quartile right here. I'm sorry, the highest surgeon volume quartile, or the numbers of patients here. And here would represent the lower quartile. And what you see for surgeon volume, for higher income surgeons or higher volume surgeons, is that they have lower transfusion rates and complication rates than the lower volume surgeons. Same thing for higher volume hospitals. They have lower transfusion rates and lower complications than the lower volume hospitals. And that makes sense, more experience. Now, the question becomes, where were Black patients treated? Black patients represent the gray line here. This looks at surgeon volume. Black patients were 33% less likely to be treated by a higher volume surgeon and 27% less likely to be treated in a higher volume hospital. This translated to higher in-hospital mortality, higher transfusion rates, and longer stays. Now, this data tells us that there is a fix out there, potentially for some of this at least. This study compared population-based data, so these are the SEER data, compared to data from equal or more equal access centers, like the VA, where men are treated equally as long as they're veterans. They have that same access to care. Or men in randomized controlled clinical trials, whereas once they get on the trial, they're pretty much guaranteed to get the same treatment across the trial. So what they looked at is across the spectrum of prostate stages and treatment, and they looked at outcome at 10 years, prostate cancer and other and all-cause mortality, comparing the general population to more equal access settings. And what you see here, the mean age of the cohorts was about 65 years. Great follow-up. SEER population-based data had 75 months. The VA and the randomized controls, over 90 months of follow-up. When you looked at the Black population, they tended to be younger across all of the studies. And specifically for the SEER population data, as we might have expected, they have a higher incidence of high-risk disease, lower socioeconomic status, and lower rates of private insurance. But they performed propensity model adjusting for all of these variants. And when you look at the SEER data, of course, you see Black men are at higher risk for mortality. They're above this one level. Anytime you're above the one level, you have higher risk of mortality. But then when you begin to factor in a lot of variables, the cancer-specific mortality favoring Black men seems to come down, but it's still higher for the population after fully adjusting for every factor that you can adjust for. But look what happened when you looked at the data from the more equal access care centers. At the VA, there was absolutely no difference in cancer-specific mortality by racial group. Same thing for the randomized controlled clinical trials. And in fact, when you fully weighted the model, it almost looked like Black men did better in the randomized controlled clinical trial of radiotherapy with prostate cancer. So this clearly tells us that there is a fix, there is a way to attack this problem. So when we look at the data, it tells us that with respect to mortality, men who should be treated, African-American men are less likely to receive any curative therapy. Certainly with surgery, African-American men are less likely to receive and be offered surgery, and they're at increased risk for receiving no treatment at all. There's certainly modifiable factors here. Physician, facility, socioeconomic factors that have to do with biases, racism, resource provision and utilization. And then on the side of patients as well. Do they not accept treatment because of fear, because of mistrust, because of cultural beliefs, loss of manhood? African-American men we know were less likely to receive high quality surgery, suffer increased complications, readmissions, and mortality. Some of the modifiable factors here. As a patient group, we must educate ourselves. How do we get access to the higher volume places? What are the referral patterns? For physicians in hospitals, this should be controlled by continuing medication, medical education, monitoring outcomes, and credentialing. Lastly, I want to talk about the era of precision medicine. This is certainly an exciting time. Our goal in this era is to offer the right treatment for the right patients at the right time. And so we want to use molecular strategies, personal knowledge, personal information from a unique family history to help us tailor a treatment for a given individual. And if you look at this example on the right side, we see an example of imaging studies. And I'm going to pick out PSMA PET as an example. We not only have the opportunity to detect disease early, we have the ability to target cancer cells using molecular strategies. So in this example with PSMA PET, a patient has a lesion defined right here by this intense uptake. The same time, the CT scan doesn't show anything. The bone scan doesn't show anything. But if you waited 6 months, you saw it by CT scan. So it's an early indicator. It has a chance to find disease much earlier and potentially offer curative therapy. With molecular targeted therapies, with drugs like lutetium-177, we can target a beta emitting radical particle to be delivered to a specific area to kill cancer cells. And this has been shown to improve survival. We're in the molecular age. We now have genetic testing for prostate cancer. There are certain genes that we know that predict for more aggressive behavior, and we can screen out patients who would not be candidates for active surveillance. Importantly, we can now, in patients with metastatic disease, with certain types of DNA mutations in the DNA damage repair pathways, we can select patients that have deleterious mutations in BRCA1 or 2 or other DNA damage repair genes who might be more sensitive to certain drugs, the PARP inhibitors, and they're now approved for this indication. And because these are heritable factors, we now have important tools with respect to counseling family members with respect to prostate cancer or other related cancer syndromes. And the question is, will underserved minorities be left out of these important advances? Shouldn't be, certainly if you're insured, because if we look across the prostate cancer continuum, genetic testing is becoming standard. It's standard for patients with metastatic disease, standard for those with high or very high risk disease, standard for those with a strong family history, standard for those with intermediate risk disease and cribriform histology, and standard for those patients who have a history of prostate or other cancers that may be part of a familial cancer syndrome, such as hereditary breast and ovarian cancer syndrome or the Lynch syndrome. So prostate cancer is very standard. It's in the guidelines now. Now, the question is it being used? And this is an example where access to clinical trials or clinical trial enrollment has basically inserted a bias against genetic testing in African-American men. We see here 17 trials in metastatic prostate cancer that have helped change the landscape of prostate cancer treatment. These are critical, pivotal trials. And the question is, what representation did African-American or men of African descent have in these trials? Well, there's 17 reported here. In 10 of the 17, race is not even reported. Where race was reported, 86% of the patients, or 6,400 men, were white. Only 3.8% of the men were Black men. And of course, Black men are dying of prostate cancer. They have metastatic disease, but they're not being recruited into the trials. This has to be intentional. Now, further, another bias is that in these trials, genetic testing was often performed. And so genetic testing may inform prognosis or predictive value. So the question becomes, are these therapies as good in Black men as they are in white men? Well, we can make an inference, but we can't say we know with such low accrual to African Americans in clinical trials and getting access to genetic testing that comes as a result of these trials. So in conclusion, what's the problem? There are a lot of problems. Prostate cancer remains a major cause of death for men of African descent in the United States, the Caribbean, and African nations. And the cause of this mortality is multifactorial, certainly biology, certainly access, certainly biases and racism. If the goal of Healthy People 2020 was health equity, it certainly has not been realized for the African-American prostate cancer patients, and corrective strategies must be intentional. Hopefully, we'll do better for Healthy People 2030. We need multifaceted solutions to address access to healthcare and new technologies. Certainly, the work that Dr. Ajewole is doing with the social determinants of health are critical. Patient and physician biases must be conquered by education and monitoring quality of care. And we certainly need to pour research dollars into differences in disease biology, funding research that will help us learn more about the incidence and mechanisms of progression of prostate cancer in African-American men. And I'd also make a call out for training and mentoring of the next generation of those investigators that have an invested interest in this, certainly Black investigators. I thank you. I also want to give a shameless plug for our conference occurring 2 weeks from now, the Conduct trial. We're going to be talking about real solutions over just sound bites in addressing healthcare disparities. This is going to be at Clark Atlanta University in Atlanta 2 weeks from now. There's a QR code for that you can scan for attending either virtually or in person, or you can just email me and I'll be happy to provide you with that information. Thank you, and I want to congratulate Dr. Ajewole and the group again on their achievements.
Thank you, Dr. Pettaway, for all the insight into prostate cancer. It was very interesting, especially around the health disparities amongst, between Black African American and our Caucasian males. It was very interesting, especially around health equity again. So thank you very much. So next, we need to pivot real quickly in the schedule, and we have, let me go ahead and bring up Azib Youssef. We're going to be doing some extra things.
I'm shocked, so I have to put it down. Good morning, everyone. I promise you, I'm not going to take long. I'm here to introduce our council member, Ms. Shabazz from District D. And we also have our state representative, Ron Reynolds. And we also have a representative from Mayor Turner office, Ms. Veronica Hernandez. We're also expecting a staff member from Congressman Al Green's office to be here. The work that we do, Ms. Shabazz, cannot complete without your support. And thank you for being here within such short notice. With that, I welcome our councilwoman. Thank you.
Good morning. Good morning. I am Councilmember Carolyn Evans Shabazz, the council member for District D, what I call the District of Destination. And we're certainly in the destination district here at the Texas Southern University, where I am a two-time graduate, master's and doctorate. So I'm very, very proud to stand here. I want to thank Dr. Pettaway for his wonderful presentation, the vital statistics and information. I certainly want to acknowledge that my colleague, Councilmember Edward Pollard, was here this morning. But if you all know anything about council members and elected officials, we try to make every event that we can. And so certainly he had to leave, and I will be continuing my District D run as well. But we both felt that this was vitally important to be here. And it's so, so wonderful to always have my state rep, Ron Reynolds here. He is such an inspiration and such a hard-working member of the legislature here in Texas. And so I want to say that although, of course, prostate does not physically challenge me, of course, it is very important because I am a wife and I am a sister, and certainly know the impact that it has on the entire family. This room should be overflowing, but certainly that means that we have a responsibility for this room to overflow to the community. Yes. So that they can realize that this is very, very vital for their own health. And so I want to thank Dr. Ajewole for the $250,000 grant. That will be very helpful. Of course, we know that more funding is needed, and we just know that this is a great challenge in the community. And it's also important that we look at Medicaid expansion and how very important that is, and you should be mindful of that. And I'm not gonna sit here and do a political speech, but you need to be very, very cognizant of the fact that there are so many uninsured people in the state of Texas, and the current leadership has rejected Medicaid expansion, which means we have just come through a pandemic. We have people who are uninsured and people who will move forward with challenges, breast cancer, prostate cancer, who may not be able to get the timely diagnosis and treatment. So be very, very cognizant of that when you cast your ballot if you have not done so. And so I want to say also on Monday, there was an unveiling of the Riverside, historic Riverside Hospital, where there will be a health hub in this community. And hopefully with the commissioner, the Congresswoman Sheila Jackson Lee and the mayor, they did the unveiling that this could perhaps help people in the community as well to be able to get early treatment and diagnosis. And so certainly I want to say the mayor was unable to be here, so I'm not Sylvester Turner, but certainly he always presents a great proclamation, which I will not read all of it, but I certainly, in the interest of time, I want to make sure that you all know how important this is to the city of Houston. And so prostate cancer is the most commonly diagnosed form of cancer and the second leading cause of cancer-related deaths among men. And I'm gonna go down, it reads all the way down, but I'm gonna certainly say Texas Southern University is hosting its inaugural face-to-face, shoulder-to-shoulder, Let's Talk About Prostate Cancer conference to present findings from the aggressive prostate cancer study, stimulate advocacy efforts, and promote prostate cancer equity actions among African-American men. And whereas with the support of those who continue to cope with prostate cancer, the city of Houston extends respect for prostate cancer survivors, offers condolences to those who have lost loved ones to prostate cancer, and stand in support of those advocating for prevention and researching a cure for prostate cancer at the Texas Southern University. Therefore, I, Carolyn Evans Shabazz, on behalf of our mayor, Sylvester Turner, do hereby proclaim November 5th, 2022 as Let's Talk About Prostate Cancer Day at the Texas Southern University. Thank you. I also want to acknowledge that Commissioner R. Jack Cagle also sent a proclamation. And then I'm standing here, as again, I said, with my wonderful state rep, Ron Reynolds, and he's going to speak to you as well. And you all have a wonderful afternoon. And let's get this information out because it is so very, very important. And thank you for the opportunity to come and share. Thank you.
Well, good morning. I'm going to be brief. Dr. Shabazz has really laid the predicate for why we're here. And I want to thank her. She is a tremendous leader and a great advocate. And we're in the district of destination. Give it up for Dr. Carolyn Evans Shabazz. I'm Representative Ron Reynolds, and I'm a proud alumnus of this great university. And I owe so much of my career to this university. I left here as an intern. I got an opportunity to see the legislative process as a member of the part of the TLIP program from former State Senator Rodney Ellis, a great alumnus of this university. And it opened my eyes to the legislative process. And long story short, I became the first African-American state representative in Fort Bend County since Reconstruction. And now I'm proud to chair the Texas Legislative Black Caucus. And this is a very, very vital program. This is so important. And Dr. Shabazz is right. Texas has the unfortunate distinction of leading the entire nation in the highest number of uninsured. Texas, we're one of 12 states that doesn't have Medicaid expansion. We're losing billions of dollars in federal funds, but more importantly, they're preventable diseases that people can get early detection for, that can be life-saving. My father, my biological father, died of prostate cancer. It could have been prevented had he got it detected earlier. When he found out, he was stage 4. And it was kind of like, hey, we gotta make you comfortable, but there's not much we can do. When people get early detection, they can have greater successes. And so we're gonna continue to advocate and champion for Medicaid expansion. That shouldn't be partisan. That should be about basic human rights. Black women in Texas lead the nation in maternal deaths. Do y'all know that? That's unacceptable. That could be prevented. And we're doing more things. So we need everybody engaged. We need more programs like this. We're so happy that Texas Southern is leading the way. TSU, HBCU, my alma mater. So y'all are at the right place at the right time. I want to thank Azir for inviting me to be here. And I have something to present as well. This is presented from the great state of Texas, from the Office of State Representative Ron Reynolds, for this face-to-face, shoulder-to-shoulder. I like that, face-to-face, shoulder-to-shoulder. Yeah, that's right, yeah. Let's talk about prostate cancer conversation, because as men, we normally don't talk about, I mean, women talk about breast cancer and things like that, but men, we don't talk enough, especially Black men. We're prideful. We need to have more conversations like this. This is so relevant. So thank you for normalizing this, where we could talk about prostate cancer, addressing the prostate cancer disparity in the African-American community, because it exists, it's real. The statistics bear it. And so I want to present this to you all as a community service award because you all are doing great work. Good to see you, Wayne Lee. Look at the diversity of this room. Look at this diversity. This is what it's all about. And I want to thank everyone for being here. Dr. Shabazz mentioned this room should be filled. I guarantee you the second annual, third annual is going to be bigger and bigger, but you all are part of history because you're a part of the foundation. You were here from day one. It's going to be, when we send these pictures out, everybody gonna be like, hey, I should have been there. You can say you were at the first annual. And I'm looking forward to seeing this grow and grow and grow. So I want to thank everyone for being here. There's a lot of places you could be at on a Saturday morning, but you're here. And I want to thank everyone from the bottom of my heart. So thank you for all the leadership at Texas Southern University. I'm going to make sure that in the next legislative session that we fund this. We have a record robust funding from our state coffers, and this should be a priority. Texas Southern getting more funds from the state level, and I know Congresswoman Sheila Jackson Lee and Congressman Al Green are making sure at the federal level we get more funds. So we combine, we will be able to sustain and even grow these. So thank you all. Thank you. Let's get a picture.
Hey, go Astros, go Astros.
So can we step over here? Okay, wherever y'all say. I follow instructions. All these doctors. There's a Juris Doctor. I got a Juris Doctor.
How about this and
I got an honorary doctorate. I would never enlist that. Right. Absolutely. Come on.
Thank you.
Go TSU, beat Jackson State tonight.
Oh, yeah.
I'll be there.
Well, this has been just fantastic. Thank you so much again to Dr. Shabazz and Representative Reynolds for the proclamations. And thank you to Dr. Pettaway for sharing with us some information, the information that's out in the field. I mean, I am in social work, that's my background, but I understood everything that he shared, and it helped me to really see and understand those disparities. One of the things he mentioned was talking about those modifiable risks, and then also being intentional about our efforts. And so with regard to this study, I'm going to talk a little bit about our intentions to engage the community. So when we started, as Dr. Ajewole mentioned, we wrote this proposal, and it was in the height of COVID. And so we knew that we wanted to have meaningful community involvement. And we knew that it had to be based on two key pieces of information. One, that it's collaborative, and two, that it's equitable. So with regard to our intentions, we said we wanted to start how best to communicate what we learned and how best to implement what was decided upon. That was our goal. Those were our intentions going into our efforts around the community, engaging community. And we also had to keep in mind, as three women, we absolutely have to have men as part of the discussion and involved in the discussion. So some of the things that we thought about, how best to also prepare for and incorporate that flexibility because we were in a pandemic environment. We didn't know, we hoped that we'd be able to come together and really build on the momentum, but if not, to also be prepared that we have to do it virtually as well. There are many community-based participatory methods and frameworks out there that are intended to bridge academia and community engagement. So for us, we started with a partnership with Sankofa Research Institute led by Dr. Asada Richards. SRI, Sankofa Research Institute, has been in the Third Ward community for many years. They have a lot of experience partnering with different institutions to make the community engagement process meaningful, which is what we wanted. So with her guidance, we were able to move forward, identifying and hand selecting those individuals representative of the various entities that we wanted to partner with, from various faith-based organizations, community-based organizations, as well as federally qualified health centers. Together, we moved forward and we intentionally structured our timeline so that each meeting fed into the next with regard to discussions and proposed ideas. We also maintained accountability of our updates, follow-ups, and came back and addressed what we said we'd address. So it wasn't just a matter of show up, it's symbolic. We really wanted to say, if someone told us something in the community or the advisory committee, we actually took it serious and we're going to come back with that information. That was our effort to maintain accountability. And last but certainly not least, we made sure to engage at times that were convenient for our community members. So if we had to have meetings on the weekends or, later in the evening, that's what we did, because it was about developing a partnership, making the partnership meaningful. So with regard to some of the strengths and limitations of the community engagement process, first and foremost, a strength is that everyone showed up, and they consistently showed up for well over a year to engage with us and work with us because they believed in the mission, they believed in what we were trying to do. So that momentum, it just reinforced one another. There was also a maintenance of genuine curiosity, respect, and a valuing of all ideas provided. So yes, you may have some doctors on the call, but it wasn't about that. It was about, what do you know? Because you're here to share your expertise, your wisdom, the things that you will not get in the data necessarily, those gray areas. And that's what we wanted with our community engagement. Now, with regard to just some of the limitations, because our reference points are different, it's expected. There were gaps in knowledge and how knowledge is to be produced, but it wasn't a gap that we couldn't overcome through communication, good intentions, and that's exactly what we did. If there was something that came up and said, hey, you guys should look at this, and we know that the study is limited in what we can operationalize, where we can get the data, you just acknowledge it. It was acknowledgement and transparency that got us through those little gaps and barriers. And then lastly, structural limitations will always be a factor. Limitations around what we can do, how we can incentivize, how to really bring people in a meaningful way. But that's just bureaucracy. And as long as we continue doing what we're doing, we can slowly chip away and address and fix those types of pieces of red tape. So working together is what will continue to erode the historical mistrust that is carried over for many decades in research and within community engagement. And if our intention remains to continue pushing for meaningful and sustainable change around health disparities, community-based participatory research is the way to go. Thank you so much.
Awesome. Thank you very much again to the audience and for everyone for staying engaged with us. We will now advance to the research group panel discussion. Please help me to welcome upstage the panelists for today's discussion. I would like to invite up Dr. Stephen Jones from Houston Methodist Hospital. Thank you, Dr. Jones, for joining us. Slide, please. Okay. All right, our second panelist is going to be Dr. Burning. Thank you, Dr. Burning, for joining us. He's one of the members of the Community Advisory Board. He's also a physician with Aries Health. So thank you, Dr. Burning, for joining us. And lastly, on this panel, we would have Mr. Frank Brown. Thank you, Mr. Brown. Mr. Brown showed up for every early morning Saturday meeting for 1 whole year. Thank you, Mr. Brown. I appreciate you. Thank you very much. So the intention of this 25-minute discussion is for the audience and participants to see what we did, engaging with everyone, in the study team. And I will get started by asking, the group a couple of questions. Would you please introduce yourself and tell us about your role on this study? I will start with you, Dr. Jones. Thank you.
Is that better?
Yes.
Good morning, everyone. Thank you for inviting me to participate in this panel. It's been my esteem or my pleasure and my honor to work with Dr. Ajewole and the whole team on this project, which when we went into it, we had one idea. When we came out the other end, ran into the buzzsaw of reality. And my role in the project was essentially as a data wrangler. What does that mean? Is that my job was to go find the data wherever it might be, pull it together, and see what we could learn from it. And beyond that, really it was just an academic discussion with Ajewole and the team, trying to figure out how we were going to make sense of all these bits and bytes and what we could do with those bits and bytes to try to find a solution to the myriad of problems we're facing in this space.
Awesome. Thank you so much. Okay, Dr. Burning.
All right. I'm Kenneth Barning, and I'm with Baylor College of Medicine. Yeah, thank you for having me here today. I'm with the Department of Family and Community Medicine, and I'm privileged to have oversight over our Harris Health same-day clinics, which is more or less like our urgent care settings for our underserved population. I have to say that my involvement in this study has been something that has been very meaningful and useful to me as a primary care practitioner and also as a director for an under-resourced platform that seeks to provide healthcare to our community. A lot has been said today that I don't want to reiterate, but I just want to reinforce for you all to know that yes, the uninsured concerns that we all share here is a real concern. And working within our Harris Health system has given me that understanding to know that yes, if most of our patient population, our family, our friends, our husbands, wives, sisters, brothers are insured, there can be a lot of difference when it comes to the healthcare that they do receive. I have to just give a thumbs up to the kind of work that is done within a community with our gold card system here. It's so unique that you won't find it a lot other places in this country. But why do I say this? I say this because when I was invited to join this group, I realized that this is the path to trying to really define how best to provide care to our patients. Social determinants of health, I think, is the key now. Even for our medical students nowadays, during their rotations, we try to inculcate into them that we are going to evaluate you on your knowledge and understanding of social determinants of health, because we've gotten to realize that prescribing Tylenol and ibuprofen every day and aspirin is not always going to fix the problem. We need to really understand what causes the problem from the root cause. Yes, so this is just to let you know how passionate I am with this whole study, but I am one of the community physician advisory members on the board, and I'm happy and privileged to be here, and thank you all for having me.
Thank you so much, Dr. Barning. I appreciate you. And I must say that even though we've had the opportunity to work with this community group, this is the first time we're seeing each other face to face. We have been behind the cameras for the past 2 years. So I'm very grateful to be able to see everyone with, I can hear their voices, but it's really good to be able to put a face to the name. So thank you for joining us today. I appreciate you. Thank you. All right, I will turn it over to Mr. Brown. Would you please introduce yourself and tell us about your role on this study?
Yes, first of all, yes, I'm Frank Brown, and I'm not a doctor, but I want to thank you for allowing me to be a part of this study group and a working group. And I guess I want to start off with how I got really interested in prostate cancer. It's been some time ago, but my brother-in-law, he mentioned to me one day that he was on an airplane with a professional basketball player, very well-known professional basketball player. And he said something about, yeah, he was on there, but he said there was something really wrong with that guy. He said he wouldn't believe how many times he got up to go to the bathroom. He said he must have a problem with his prostate cancer, but a number of times, prostate, but he said, in fact, I think he may have had prostate cancer. Well, I really wasn't really tuned in to prostate cancer very much, but it really increased my curiosity on it, and I really got to wanting to know more about it. And as I looked into it, then I realized that it was, one of the most common cancers that are out there, and but you don't hear anything about it. And here, a lot of people die from different things, from anything from heart attack, cancer, and other forms of cancer, and complication of diabetes and everything. But you never hear anything about it. So I think that the information is not there. I think that it's just that it's very personal to men and everyone. And I felt that being a part of this group, it's something that I felt was missing, and it would allow me to be a part of something to help communicate the information and have identified some of the factors that contribute to that. And so that's the reason why I'm on the committee and honored to be on it.
Awesome. Thank you so much, Mr. Brown. I appreciate you. And in reflecting on what Mr. Brown said, initially when we started out, we were only going to do like an introduction session with the community work group for 1 month. I was out on maternity leave. Dr. Ndefo was, handling that session in my absence. And at the first meeting, she was like, no, we need to do additional information because we realized that the basic understanding of where's the location of the prostate. Most people did not even know where it was. They didn't know the function. They didn't know what it looked like. So we had to spend 3 months, like 3 meetings. Dr. Onta was one of those that actually came to help bring, the basic understanding of what the prostate is. So this tells us how much, the missing education, basic education of the things that we need to do. So thank you again. I will go to the second round of questions, and I will start with you, Dr. Jones. Can you please share some of the key takeaways from the study design or from your involvement in the study?
Sure. I think Dr. Pettaway did a great job of making the argument that this is multifactorial. There's a biological component, and there's the environment itself. But we all share a lot of things in common. One of them is we're all people. We all have the same DNA. It's different between individuals. There are racial differences, of course. But the truth is, I think about 90% of human suffering is self-inflicted. Prostate cancer itself is in that 10%. The rest of the consequences that we've been dealing with here, we're trying to tackle here as well, are in that 90%, where these are problems we've caused ourselves. We have issues in our environment. We have issues in the way we govern ourselves. Talk about things like the Medicare expansion. The refusal to expand Medicare coverage to the rest of our population is self-inflicted. That is a choice we are making as a society. That is not a rule of physics. The big takeaway is truly how multifactorial this is. The biological part of it, we'll study it, we'll understand it better, but there may not be very much we can do to change it. Modifiable risk factors are a lot of the things that we're doing to ourselves. And longitudinally, the thing from the data side, I'm a data nerd. That's really what my, I have lots of titles. As Houston Methodist, we collect them. I'm winning that game, but they all translate to data nerd. The challenge with this too is when we try to study these kinds of things is the data set that we needed to do this project to, ideally doesn't exist. And there's many reasons for that too. We had to sew in the social determinants of health mostly from an indirect way. We're using census data. We're using something called the Area Deprivation Index, which I was mentioned on the screen earlier. But those are all things that are attached to a census block, also known as an address. When was the last time you saw an address with prostate cancer? We need to attach these components like where you lived, where you were born, how long you've spent your time in a life history to really understand these things, to do this right. And there just doesn't seem to be a societal will to do that right now, but that is also something we can tackle and change over time. This is not going to be an easy overnight solution, but these are the conversations we need to start having to decide as a whole where we want to go. How do we want to live? We share biology, we share the environment, we share the world in which we live. And arguments were made here too that from the biological perspective, prostate cancer itself appears to affect men of African descent earlier than other races. There we go again. It's like so now we're talking about insurance coverage in the US, we don't have, most people don't, or a lot of people don't have coverage until they reach Medicare. And if prostate cancer is emerging in people before they're 64 years old, they may not be covered. And there's another argument to increase insurance coverage because access is clearly a modifiable risk factor for this disease. So the take-home message for me was we need better data set because data nerd. And it will also help us understand this better. So because What about the neighborhoods we live in? For the past 50 years in the US especially, we've been segregating to live together in different ways because we've had unprecedented mobility in society. But we have systemic structural issues that are putting people living on top of toxic waste dumps when we shouldn't be doing that. And I guarantee you that is affecting populations disproportionately. Those are things that we can address as a whole. And I think that this is the kind of forum where we start having those conversations.
Awesome. Thank you so much for sharing. I appreciate you. Dr. Bonnie, you want to share some of the key takeaways from the study or your involvement in the study?
So for me as a clinician and also as an educator, there are always a few questions that I seem to ask myself every time I'm invited to join a study or my curious mind tells me to be part of a process to think through the whole process. There are a lot of disease processes that we study and we teach learners, and we have criteria to define these diseases. So every time I look at something like diabetes, hypertension, and I always see some of the predisposing factors, and it's labeled as being Black, it's a huge predisposing factor, and that even adds into criteria for determining what my 10-year CVD risk score is going to be and all that. I try to ask myself, is my Blackness really that dangerous for me as a person who is alive? And that calls into question, that intent for us to figure out, is that what the problem is? Or are there other confounding factors that present with the Blackness that we might be able to solve to try and eliminate my being Black being a risk factor for me to be at high risk for that mortality process? And I remember being at a conference where the speaker was trying to present an idea of if we were to pull away from using race as a defining criteria, then maybe our thought process for diseases might be different. But you step back and you also think of all the challenges that we have assessing healthcare and all that, and you ask yourself, if you pull that back, then what are the dangers that we face when already those people are not getting the right kind of screening or healthcare services that they deserve? So it becomes very complex, as everybody has talked about. And for me, for this particular study and my involvement, one thing that I think I talked about this in a lot of our meetings, in subtle ways, there was a study done within our community here within Harris Health that ended up with the system agreeing to the fact that women within our community can be screened with a mammogram on a yearly basis. And why was this decision made? It was made because of local action, because of local studies that were done to define and identify that the predisposition to, breast cancer, aggressive breast cancer, was higher within our community as compared to other population data out there in other states and cities. So we have that, and that is the reason why we are able to do annual screening with mammograms for most of our patients within the Harris Health system. So my belief is if we are able to identify local challenges and be able to define the things that really pertain to us as a community, then that would also help us micromanage what the problem is and find solutions to some of the problems that would help at least ease the challenges that we have when it comes to diseases such as prostate cancer. And that's why I'm so happy that I was a part of the physician, advisory community group members. And I think we will continue to collaborate with Dr. Ajewole and his team as long as they want us to be part of this process to try and at least find some answers to these, concerns. And secondly, educating learners. We have a lot of recommendations that comes and goes, and they modify it from time to time. Every time I'm teaching a learner and I'm telling them that this is what the recommendation is. And I know that, for, minorities, the predisposition is a little higher, then it becomes a concern for you to try and juggle should they screen or should they not? Because that information you are giving them is going to stick with them, and that is what they are going to push forward as clinicians. So understanding some of these and trying to ensure that we provide our learners with the right information and tools to go into the community and provide it to the patient population is very key and important to me. And I hope we're able to find some answers to this. Thank you.
Thank you, Dr. Burnett. I appreciate you for sharing. Thank you so much. Hey, Mr. Brown, I would ask the same question. Would you please share some key takeaways from the study design or from your involvement in the study?
I think I would like to piggyback on data guy here. Being an engineer, I look at data a lot, and that helped guide me. But anyway, I think that we have a lot of hurdles to jump over to get to where we want to go. But I think involvement-wise, in the study, I think it should be going toward educating everyone, and I think we can talk about prostate cancer in words and flyers and everything, but until I think people really realize from data that you see what their risk factors are, and the data of how we are affected, particularly African American. You have to visually see a lot of times, see something. And if you can see where we are impacted that way, rather than just be told, well, we're impacted and you should be screened and everything. I think that we need to definitely work on, and the takeaway from the study is that it is allowing us to develop that, a lot of this data, and it just be a matter then of how we are able to provide that data to the community.
Awesome. Thank you so much. Thank you. All right, we are running close on time, but I would, like to take one last question. If you can, briefly tell us what recommendations would you have for similar research work in the future? Because obviously this is just a springboard to many things that will come in the future. But as we plan to do things in the future, what recommendations would you have? In about a minute, please. Thank you.
Lightning round. First and foremost, I recommend that we find ways to support in a sustainable way the longitudinal collection of this kind of information, especially the social determinants of health. I'm not sure where that duty belongs. It seems maybe it is in healthcare because we're dealing with the end result of it. I don't know, but that is something we as a society should address. And for projects that Dr. Pettaway also mentioned before, where I'm going to miss the name, but the longitudinal registry. If there's a way to interview the members of the registry and say, where have you lived? How long were you there? What kinds of occupation were you in? What have you been exposed to? Those are the kinds of things we need to be able to attach to the outcome in a sustainable way. Back to that 90% self-inflicted. When I say self-inflicted, I mean stuff we do to ourselves, stuff we do to each other, not just society as a whole. If we can improve access to care, Dr. Pettaway made a solid argument that just by changing access to care, we can improve these outcomes. That is a societal problem we can address. And then to touch on education as well. Part of the problem, I think, and this is just me thinking, is that if you are trying to have a conversation with someone that doesn't have the background to understand the context of why it's important that you participate in a clinical trial, yes, medicine shares a dark history. We have a stain on our soul for things that have happened in the past. We should acknowledge that up front. Say things are different now. We're trying so much better to dig out of that hole and go forward together. And these studies are strengthened by inclusion and participation from a diverse population. We learn the truth from those kinds of studies. When we just look at it, we're just doing studies with people that look like me. We don't learn about people that look like me. And this is a bigger problem than just white people with prostate cancer. And clearly it disproportionately affects men of African descent. So that means it deserves our attention and it deserves our focus on solving that problem and making sure we do better with inclusion going forward.
Awesome. Thank you so much. Dr. Burnett, same question. Any recommendations for future works?
I think my recommendation is very simple. I believe that when you talk about Methodist Hospital and doing any study, the first thing that comes to mind as somebody who works within the under-resourced, healthcare system is, where can you place my people? So if we can have a broader, database that cuts across, such as those who are insured, who are seen in the medical center setting versus those who are seen within the community clinics and other OHPs, I think this would really provide us with a very clear picture of the disease burden within our community and a very good idea of the impact of this social determinants of health on the disease process. I would also reinforce the fact that understanding the disease process and being able to educate the community is going to be key. I love my mom, I love my sisters, and I would say that when it comes to something like breast cancer, we are doing an amazing job at really, blowing the trumpet and making that sound that deserves to catch the attention of everyone. If this study can lead us to a point where we can really say we are going to also be very loud about prostate cancer for people to really engage with us and ride this train to ensure that everybody understands it and we have a clear path to how we are going to really support and manage the disease process, I believe that would have served the community really well. Thank you.
Thank you for sharing, Dr. Bonin. I appreciate you. Mr. Brown, any recommendations for works in the future?
Yes, was it, everything come down to funding, right?
Yes.
Okay, well, my recommendation is to continue with the research and see exactly the areas that you need to target to, everything from the social to insurance things. I think that the recommendation is to continue with that. But one of the things that I think we need to do, my recommendation is to target your doctor to buy into this, because they are the ones that can actually help you, particularly if you have insurance, to make sure that you are screened. Because like with my doctor, every 6 months, I have the blood work and I always look at my PSA. And you, of course, you can take an active role in that as well, because it's not just a doctor. You have your chart to be able to pull that up and be able to look at it, and you can monitor all that yourself. But anyway, I think that you definitely need to have the doctors be involved and be able to have access to this data that we have, that we're coming up with and everything, because I'm not sure that they are up on everything. They know that, hey, okay, it should be screened for it and everything, but it doesn't appear to be a priority to them, at least to me. I mean, you almost have to ask to even have it done, have it screened for. So I think they need to be educated, and I think a lot of the research should be channeled to them, so they would be very much involved, and I think that would help from that standpoint. But I definitely feel that there's a lot of work that still need to be done from the research and study all the factors that comes with prostate cancer.
Thank you so much, Mr. Brown. Audience, please help me to applaud our panel session. Thank you for joining us and for sharing your great insights. You may please go back into the audience. I appreciate you. We are looking, at the time, we are definitely over time at this point, but we will continue to move along with the plan for today. Our next thing now is for us to be able to discuss the findings from this study. And, Dr. Pettaway gave that great, information to us about the background and the issues, the problems with prostate cancer. But now we are going to discuss what exactly did we find from this study. Okay, just a second. Okay, thank you very much. All right, so we will start off by looking at the findings from the data standpoint. Okay, so here is showing us the aggregate of the number of patients that we were able to, pull out from the Houston Methodist Hospital Cancer Registry from 2016 to 2021. The first set is looking at all the patients, and the second set is looking at African American patient population only, where we had about 866 patients in the study. Then here we are looking at the summary of the findings, by the time the data analysis was done, looking at the social determinants of health, medication-related information, comorbidities. These 5 points were the things that came out to be significant as it relates to what are those things that could lead to an increase in the development of aggressive prostate cancer versus non-aggressive prostate cancer among African American men in our study. Number one being age, and we know there is really nothing we can do about age, right? We have to keep growing, as the clock is ticking, we grow older. So that's one of the findings. The other one about the medications and the ADI state rank, I will talk about those in upcoming slides. So here is talking about a medication, thiazide and thiazide-like diuretics. Some may ask, what is this medication? So this is one of the medications typically used to treat hypertension. An example of that is hydrochlorothiazide. Some people will call it water pill. Most people, in the community consider that to be called water pill. So what we found in our study is that African American men taking thiazide-like diuretics were less likely to develop aggressive prostate cancer. And in that same vein, use of thiazide-like diuretics may actually protect against prostate cancer. And you see our disclosure there saying this is just an hypothesis because our study sample is small, but we are going to explore these findings in the future. Again, another medication, angiotensin II receptor antagonist. Our study showed that African American men taking angiotensin II receptor antagonists were less likely to develop aggressive prostate cancer. And in the same vein, use of angiotensin II receptor antagonists may protect against the development of aggressive prostate cancer. Examples of this type of drugs are things like losartan, valsartan, or milsartan, typically used to treat hypertension. Again, this is a disclosure saying this is still an hypothesis because our sample size is small, but we would explore more in the future. Direct vasodilators. When we look at this particular medication, contrary to the first two that I talked about earlier, this is actually showing in this study that African American men taking direct vasodilators may be more likely. They are more likely to develop aggressive type prostate cancer. And as such, use of direct vasodilators may increase the risk of development of aggressive prostate cancer. An example of this is hydralazine, one of the drugs used to treat hypertension. Of all the variables that were included in the data model, several social determinants of health-related variables. And like Dr. Steve said, these variables are not associated to each individual. These were variables associated to an address, to the zip code. So we pulled in as much census-related data as possible. The only one that came out to be significant is the area deprivation index. So basically, the way we would explain this is that a neighborhood with a higher ADI is considered to be economically disadvantaged. So what we found in our study is that African American men that were living in an economically disadvantaged neighborhood were more likely to develop aggressive prostate cancer. Again, tying into those key issues of social determinants of health. And as such, Hypothesis here is that living in an economically disadvantaged neighborhood may increase the risk for developing aggressive prostate cancer. I am sure if you're like me, questions are coming to our mind. Okay, what are we going to do? Are we going to relocate everybody? Pull everybody into a rich neighborhood, pull everybody into, a more economically stable neighborhood. So these are questions that we have to explore as we go into the future, and how can we develop interventions that would positively influence these key findings from our study. Now I will talk a little bit about some of the findings from the community standpoint, looking at our works with community work group and community advisory board. One of the things that came out glaring clear, which I believe Dr. Burning and Mr. Frank did mention, is the lack of awareness about prostate cancer. If I can, by the show of hands, how many people know October to be Breast Cancer Awareness Month? Okay, very good. How many people here are aware that September is Prostate Cancer Awareness Month? Okay, about 50% of the room. So that tells us that we need to do more to paint our streets blue. Let's get the blue color out there in September. We see a lot of pink fluffs in October, but in September, and actually all year long, we need to put in more efforts in advocating, raising awareness, and taking action for prostate cancer. So one of the things that we did co-create together with the community work group are educational materials. The wordings on these flyers were not my words. We didn't get them off the internet. These were words that were developed in conjunction with our community work group, because we did ask the question, what would make sense to you? What would make you get up and say you need to ask the right questions? Are you asking your doctor about PSA, DRE? Am I at risk for prostate cancer? Those type of information. And the good thing is this content is already available on our website. You can go in there, download. You can, send a request for us so that we can mail them to you if you would prefer us to be able to do that. The other thing again here is, what are the actions that we as Texas Southern University that we are taking? I'm excited that we're able to engage across the board with multiple stakeholders, elected officials, funding agencies. And we have a couple of videos from CMS and ARSA, validating the work that we do. But some of the things that we are going to continue doing in this regards is establishing a center here at Texas Southern University as we continue our efforts in prostate cancer. We are going to establish a funding mechanism called We Roar Against Prostate Cancer Fund. We are going to talk about, Dr. Dakota is going to lead us in that shortly. We are going to optimize our website and put in information, content that is easy to understand and read by the community, creating flyers, engaging in print, mass, and social media, and also advocating, engaging partners, advocates, elected officials. These are representatives that will get money and funding for the great works that we do. I also do want to point your attention to what we have on this other side, which is called the Catalyst Initiative here at Texas Southern University. This is an initiative that we came up with, with the support of VP Penn Marshall, Dr. Lale, and the president of TSU, President Licia Young, and we are able to put together a mobile unit that we expect to be delivered in 2023 late summer, where we would be able to go out to the community to address disparities. Access to care is a problem. We've seen it. Dr. Pettaway talked about it extensively. So with these units, we'll have a mammogram suite, we'll have primary care suites, we'll be able to do community engagement and offer services on a telehealth medicine basis. So this is an initiative that I want to share with the group, that we have a lot of great things that are in the pipeline for us here at Texas Southern University. And then this here is also showing some of the great works and efforts that we have put in place and that we will continue to do. Several of these things on this slide are showing initiatives that I've had the opportunity to lead, implement, and I continue to do myself and so many, of our team members here at Texas Southern University. The Community Engagement Core, NIH funded Breast Cancer Screening Center, where we offer no-cost screening for uninsured and underinsured women within our community. This very grant that we are talking about today, the Prostate Cancer Project, as well as CDC HHD funds, where we are devoting efforts to address health equity or advance health equity in our community. This is Texas Southern University. We have opportunities to train, to advance health equity, increase access to healthcare, and build trust within the community. And future directions, right? $250,000. We've been able to stretch that dollar. We stretched it for 2 years, and we're here, making the best use of what we have, but we still have work to do. Longitudinal collection of social determinants of health-related data, collaboration with minority serving institutions so that way we can get data from the population of interest, benchtop research to be able to figure out all those things that we are seeing, the signals that we are seeing from the medications that I shared earlier. Does it even have any impact on the benchtop side of research? And also ensuring that we publish the findings of this study so that we can make decisions in the future. And that would wrap up the study finding for today. I will turn it over to our MC, and she would introduce the next speaker. Thank you so much.
Thank you, Dr. Ajewole. Great information. And so next on the list, we are going to bring up our next keynote speaker, Dr. Marino Bruce, Associate Dean of Research at the Baylor College of Medicine. Thank you.
Good afternoon, everybody. Y'all can do better than that. Good afternoon, everybody. All right. So we're going to try to make this, we're going to try to keep this within the time limits, but you all have been sitting for 2 hours, so I need you to stand up and stretch. And so while you're stretching, can we put the slides up? And can I control them from here? Perfect. All right, thank you. Thank you. Hopefully you feel a little bit of energy coming in. The average attention span is about an hour. So, and plus you've been sitting. So we wanted you to stretch a little bit as you have been taking in a great deal of information about prostate cancer, a little bit about health disparities, a little bit about health equity. We're going to talk a little bit more about social determinants of health, faith, and prostate cancer. And we'll talk at the end about what should we do a little bit differently. How do we think about it? What is it that we need to do? So as part of any presentation, it's always important to acknowledge things. I wanted to acknowledge some of the funding that I have from the National Institutes of Health. That's the National Institute on Aging, as well as the National Heart, Lung, and Blood Institute. Always acknowledge colleagues that contribute to this work. That's Drs. Bettina Beach, Elizabeth Heitman, Keith Norris, and Roland Thorpe, who we've been working together for the last decade now in many different types of studies and research, training, and mentoring. The Faith, Justice, and Health Collaboratory Board of Advisors. We'll talk a little bit about that, where the Faith, Justice, and Health Collaboratories, where we bring folks who have interest in science and interested in faith together, and we talk about how do we address some of the health and faith issues together. And of course, statements in this presentation are mine and mine alone. Don't attribute them to the University of Houston. Don't attribute them to the National Institute of Health. You can attribute them to me. That way, if I get in trouble, they don't get in trouble. So disclosures, this is also important, and you'll see in this in many scientific talks. I am the chair of the board of directors for the Medgar and Marilyn Evers Institute. That's in Jackson, Mississippi, and I'm pretty sure those of us who have been around, we know who those two people are. We won't talk about that today. Lifetime membership of the NAACP, there's a theme here, right? I'm also divinity trained. I'm ordained Baptist clergy. I'm active. I serve in church and have been doing so for the last 20 years. And this is what I mean in terms of what justice is for me. The pursuit of optimal health for marginalized populations, especially Black men and boys, is a justice issue. It's not only a health issue, it is a justice issue. And justice, very simply, is making right what is wrong. So I disclose this in every talk that I do because I want folks to get a sense of where I'm coming from, okay? I am a scientist, but I'm also in ministry as well. But more importantly, I'm a human being, okay? And so much of what we see, as we heard in comments earlier, has to do with more than just biology. It has some things to do with our history, where we live, the things we get engaged in. So that's all part of what makes us human. So quickly, we're gonna talk about getting on the same page. We're gonna talk a little bit about faith and health. I don't have a whole lot of time to talk about that. And then we're gonna talk about consideration of context in terms of what we may need to do differently. So I'm a word guy, okay? I'm a word guy. I believe in making sure that when we use words, we have a common understanding of what they are. So every talk that I do, you'll see me talk about getting on the same page. So we spent a lot of time this morning sort of talking about what some of the issues are with respect to African-American males or Black males or males from an African descent. That's an interesting conversation, those distinctions, but we don't have time for that today. The big deal is that you'll see that Black males have a higher mortality rate than other groups of males. This is what we know. And we see that in cancer, in terms of cancer relationships for cancer mortality. You can see in the general population, thinking about general mortality, we see the same type of pattern. Same thing when we look at what we're here to talk about today, cancer. We'll see those same type of disparities. Black men, African-American men have disproportionately high levels of illness, chronic disease, and premature mortality. We see this we can look at heart disease, we'll see the same patterns that we do as we look at cancer. One of the key takeaway points is that this population has been more likely to get sick earlier and die younger than any other group of males in the country. So, health. We've been talking a lot about health. It's important to understand that, what do we mean by health? Sometimes there's a conflation between healthcare and health. We often will say, we'll use those terms synonymously. They're not. They mean different things. So when we talk about health, we're talking about a general, this is, by the way, is what we find if you look it up, right? This is what you see if you look it up, you go to dictionary.com and say health, this is what you find, right? General condition of the body or mind with reference to soundness and vigor. Okay, that's pretty general. But freedom from disease or ailment, okay? So one of the things about definitions, they often are culturally influenced. So when we say freedom from disease or ailment, that puts it in the context of treatment and disease, right? But one can be healthy in other ways than just being free of disease. And other people, and also one can be sick in ways that are different from being diseased, okay? So it's important that we think about and interrogate simple words that we use in health. So how is it being used? What are we really talking about? That's really, really important. When we talk about determinants of health, right? You could see from the site, we're talking about something that has been put out there since 1999. When you think about what are the determinants of health, you could see that you'll see a few differences here, but you'll see clinical care is 10% of what makes us healthy, right? You'll see that genes and biology is another 10%, okay? The physical environment is 10%. But when we look at social and economics factors, it's 40%, as well as health behaviors. So we'll spend a lot of time talking about 10 or 20%. And now when we think about precision medicine, 30% to the ignorance of the 70%. In terms of what makes us healthy or what impacts health. So it's important that we keep these things in mind in terms of where our attention may be and where our intentions are. Also want to talk about social determinants versus social needs. Social determinants of health has become a common phrase but we need to have clarity in terms of what we mean by social determinants of health, okay? When we talk about social determinants, we're talking about those things that operate at an institution or sets of institutions or at what is known as a structural level. There are ways in which institutions work that work to the advantage of some and the disadvantage of others, okay? That's what we mean when we say social determinants. We're talking about those institutions or structures that are operating in a way that causes differences in outcomes. What a lot of folks talk about are social needs in terms of food, housing, transportation. They tend to be social needs, and that tends to be at the individual level. Now, both are important, okay? So I'm not saying one is more important than the other. Both are important, but it's important to understand which level we're operating. So when we're talking about social needs, we tend to focus on individuals and their group or groups and their social needs. It's important. It's important to know which level we're operating so that whatever we come up with is at the appropriate level. So faith and health. Why are we talking about faith and health? Well, that's an area of interest to me. However, when we begin to think about faith, religious or spiritual institutions, that's one of the institutions or sets of institutions that can help, that can operate at the structural level as well as the individual level. So faith is a critical component in Black life. This we know, okay? There's very little debate about that, okay? So again, we see pictures like this, you know, a lot of times when I ask questions, what they see, they think about Sunday school, right? Because you got the books or maybe in church, they see that as a hymnal or something like that. That's pretty common way in which we think about when we talk about faith. But this is another, in terms of when we think about Black life, this is another visualization or depiction of faith, just like this. So there are multiple faiths. There's a variation in faiths within Black communities. We have to begin to broaden what it is we mean when we think about faith. But as in general, when we think about churches or the Black church, one of the things that we see is that it has been a safe space for communities. It's been a vanguard. Now it has its challenges. We don't have time to talk about them today. Okay, we don't, and it does. Okay, one can critique an institution that you belong to, and I do when I'm on the other side from a ministry perspective, but it's important to understand its historical place. It has been a place where it's been safe, in particular for Black individuals to not only come to get spiritual messages, but to also get information about jobs, housing, family. It has been one of those institutions that has basically launched Black communities and protected Black communities. So it's an important one. So just to give you a sense of perhaps why I may have been invited here, is that I've done some work looking at the relationship between religiosity or behaviors, religious types of practices, as they have implications for Black and white men with prostate cancer. These are two recent publications that a group and I have been focused on. One is religious coping and the quality of life, looking at those group of Black and white men and the North Carolina area. We drew data from the registry in North Carolina, and we were able to collect those data, and we looked at, we were able to collect information about religious coping. In other words, did they have a positive either perception about religion or God or closeness with God, or a negative one, right? Those two forms of religious coping. And we saw that we did not see differences in the regression equation saying that that the relationship between religious coping and quality of life was different between groups. However, what we did find is that Black men in the study had higher levels of religiosity, but they also had higher levels of disease, right? But the point of these studies, these are what's known as hypothesis generating types of studies. I wanted to get a sense of what the patterns were. Did faith matter? And in both of these cases, yes, they mattered in terms of religious coping, and it also matters in terms of just going to religious services. Okay. So when we looked at mobility limitations, which again, when you think about those who after cancer treatment, sometimes you have, you're not able to have the strength that you had, or you may have some physical difficulties. And so we were looking at that. And we found that those who had more frequent attendance at religious services had better outcomes with respect to limited mobility. In other words, they had a lower likelihood of being limited in terms of their ability to walk a quarter of a mile or climb a flight of stairs. Okay. All right, but that's the only tip of the iceberg. Those two studies like that, you'll find, but that's only the start. We're not at the end. We're only just scratching the surface. So what do we need to do? What do we need to do differently? What do we need to do next? It's a consideration of context. We need to dive deeper, and we need to understand a little bit more about the context in which people are in, the context in which they're studying. So when we think about Black Lives Matter, I put a question mark there, right? There's a reason for it. Anyone? Who is that? Emmett Till. This was taken, I think it was 13, 14 years old, okay? This is the Emmett Till that we know. Spent a number of years in Mississippi, and 10 years to be exact. And so when we talk about what's going on, what has happened, this happened in the 50s, okay? Right? In the 50s, that someone that was 14 years old, 14, you need to think about that, 14 years old, not 24, not 34, but 14, got brutalized like this. But we see this, okay, when we talk about lynching. If you're ever in the Jackson, Mississippi area, go to the two museums, the Civil Rights Museum, where one of the most stunning exhibits is where they actually have poles, beams with the names of everybody that's been lynched in the state of Mississippi. And one of the things, the starkness of it was that all of the names are on one beam, right? And so if I'm looking this way, you see that one. You step to the side, you see 5, 6, 7 more of just names and their offenses. Okay, so when we think about Black Lives Matter and where it comes out, this is the context, this is the historical context in which Black men have been dealing with. And then we have this, present day. So there are things that are going on in Black life, and particularly the lives of Black men, that we need to take into context. Yes, the biology is important, but that biology, I would argue, and some of the other work that I do, is impacted by the social and physical environment. We don't ask those questions. We don't ask those questions enough. So one of the things we need to do is, when we think about churches, we need to look at that context as well, because that very well may be a buffer of sorts. But when we do so, we need to think about the diversity within religious institutions. For example, I put this up, when people think about Baptists, they think it's one thing. There are 27 denominations of Baptists. 27. And this is just a few. Of Baptists, we haven't even gotten any, we haven't gotten to Methodists, we haven't gotten to Presbyterian, just Baptists alone, right? So we need to, and they all have different interpretations or different ways in which they practice the faith of being Baptist. There's a book, What Baptists Believe. It's a little short book, right? But you have 27 denominations, that little short book that they may all give new members, how they practice it can be very, very different. And that can have implications for the degree to which religious service attendance may or may not have an impact on one's health. The sacredness of the setting, and this is important for those who are interested in working with faith institutions, we need to think about that setting. Oftentimes, we think about faith institutions and saying, well, on faith-based work, or is it faith-placed or faith-based? Faith-placed work is just in a church. And that's fine if it's just a setting. But if you're saying faith-based, you have to begin to think about what is it about the structure of the faith that's practiced in that given setting. That's really, really important. It's really important. And these were two pieces that were written, as you can see, in the late 90s that talked about deep structure versus surface structure, levels of involvement of faith organizations. It's whether or not you are faith-placed or faith-based, doesn't really matter. But you need to know that so that if you see particular outcomes, you can get a sense of why something may work or why it might not work. Okay, it's important to do so. So what does faith-based mean to church and spiritual leaders? We have a sense of what we may mean, scientists, as what faith-based means. But what does it mean to them? A lot of times we don't ask, okay? Prayer and scriptural considerations can vary by context. Some will have scripture first, then prayer. Others will have prayer, then scripture, okay? Getting a sense of what that means is really, really important. How does the conceptual framework of a study line up with the theological foundation undergirding churches under consideration? Okay. Theory has to meet theology if you're going to do this work. If it does not, what we propose may not work as well. So we need to know that. Is it an individual focused or collective focused? You could get a sense of that by getting a sense of how churches or other faith institutions go about their work. We need to know that. How do studies line up with congregational activities? We often place studies in church, but we don't understand how it affects actually the church itself. Okay, it matters. We need to do that. And so can study activities alter participants conceptualize church or faith? When we go into a setting, we're going to impact it. We need to think about that. It's really, really important. Again, this is not saying that we shouldn't do it. It's just when we do, we need to think about do we understand the setting enough, right? But also understand that we're going to impact the setting. So when we work with health ministries, for example, we're bringing information. Well, that may be information that they hadn't had before. What do they do with it? Let's make sure that they have a clearer understanding of it when we work, because they may distribute it. How do they distribute it? Is it just sending out? Are they talking to people? We need to know this because we're bringing this to them. We want to make sure that it's to their benefit. Last thing I want to say is talk about a covenant, right? We hear this word in religious settings. It's really, really important that we understand that, right? We don't talk about contract, we talk about covenant. And one of the key things about that is parties in a covenant are equal and a bond is sealed by a vow that each would meet their respective obligations. That's really, really important. So we're going into a sacred setting and we're talking about what it is we're going to do. We got to make sure we do that. Because when we don't, we're violating the sacredness of the setting. Okay, it's really, really important. So I'll say this. If we're going to do this work, if we're going to talk about dealing with faith institutions, understand this operates at the base. It's about in lifting others, we rise. And if that is not what our study is about, then we need to think about that and figure out how there's more alignment in terms of what we do in the scientific realm as we engage the faith realm. So with that, I will end. Thank you for your attention.
Thank you, Dr. Bruce. Thank you very much. So next, we're going to quickly run a HRSA video for you guys to review real quickly. Okay, scrap that. We're actually going to pivot real quickly, and I'm going to call up Dr. Dakota. Thank you very much.
Thank you so much. It's so good to see you all. I want to give another round of applause for Dr. Bruce. I really enjoyed the presentation. I want to give him another round of applause. Had an opportunity to learn a lot. I learned something a long time ago, and it says, don't tell me your values, show me your budget, and I'll tell you your values. And I learned that many years ago, and I thought that that was very appropriate for how individuals and how organizations really put their money where their mouth is, if you would. We are at a precipice within our communities, of course. We know that there has been an increase in various levels of advocacy for Black and Brown individuals over the last couple years. And we've been having to be very careful because we know that there has been a lot of virtue signaling. There's been a lot of guilt funds thrown our way. I work at the institution. I guess I should take a step back and introduce myself. My name is Dakota Doman, and I have the pleasure of serving as the chief of staff here at Texas Southern University. About 5 years ago, a very close friend of mine, he lost his uncle, who was quite young. He was 43, and he lost his uncle to prostate cancer. And one of the things his uncle told him was, Bobby, when you turn 35, I want you to get screened. And so this happened many years ago, and he's a close friend of mine. And when he got to be 35, which was last year, we're all around the same age, he came to a group of us, and he didn't want to do it by himself. He wanted to have a community. So me, him, and 3 other of our friends all went to go get screened when we turned 35. And I thought that that was very important. But if it had not been for the suggestion of someone who unfortunately did not have the opportunity to get screened early on, and I'm sure that you all know about all the statistics that show in terms of the prevalency of prostate cancer in the Black community. And then, of course, in terms of the screening, and if we get detected in time, the way that we will be able to remediate our health and all of those things. And so I'm very fortunate to be here with you all today to speak a little bit about my experience with just screening for prostate cancer, but then also to advocate for a fund that is going to really increase the awareness. Now, I won't spend a lot of time talking to you all specifically about the dreaded disease and the outcome of that, because you all have a lot of that information already, and perhaps you know this a lot more intimately than that of even myself. But I do want to raise your attention to a fund that you or your company can donate to so that we can continue to increase the awareness so that individuals who may be impacted by their disease have the opportunity to receive, again, that awareness, which is that really big piece, right? I am a advocate for change management. I'm sure that we have some individuals in here, perhaps with a Prostate change management certificate. And we're talking about making changes, when we're talking about going from where we are to where we need to be or where we can be, we're talking about making a change. And in that, there's an acronym, ADKAR. Raise your hand if you ever heard of that particular acronym before. ADKAR. Okay, fantastic. I may be able to do a little professor, VP Penn Marshall. I may know a couple of things that may not be as prevalent in the room. So ADKAR is a process that we use when we say, how do we make changes in any realm, right? This can be for an organization, a personal change, what have you. And that first A, what do you all think it stands for? Awareness. Awareness. That first A is awareness. There has been tons of literature produced, research conducted, showing that without awareness, it is virtually impossible to make a change, right? So awareness is the first A. The D stands for desire. You have to have the desire to change. The K stands for knowledge, right? The other A is ability. The last R is resource. And that is the change management process. So going all the way back to awareness, the thing that I wanted to spend just a couple minutes, I only have a couple minutes talking about, is how can we increase our awareness within our particular community so that individuals understand what this disease is and how they can go about mitigating this particular disease. And that's why I really enjoyed Dr. Bruce's presentation, because I once before too had been told, well, so much of his health issues is just DNA, right? I am the way I am because of DNA, whether it's diabetes or high blood pressure or high cholesterol, whatever it has you, it's just your DNA. So you really can't do a whole lot about that. That's just, the DNA lotteries, right? And I learned some things along the way that Dr. Bruce so eloquently highlighted. So again, in my time here, I just wanted to highlight the fact that we do have a program, and I have it in my notes because I want to make sure I get the funds correct. We have a roar, because we are Tigers, a Roar Against Prostate Cancer funding program. And at that program, we have two different levels. We have an individual level, and we have a corporate level. And I just wanted to lift up for your considerations for your personal investments, or how can you go back to your companies that say we are interested in advocating and educating and protecting and serving Black and brown bodies? What can we do organizational wise? Because at the institution, I have the opportunity of working with many organizations, and I've been here for about 7 months. And one of the things that I've noticed when we're talking about partnerships, some companies like to say, well, if I come and give you a check, if I come and give you a small investment, then that makes me a partner, and I go on, you never hear from me again. And that's not the way that Texas Southern University actually wants to do partnerships. We want actual true partners, because we know that those are the things that will advance our mission. And our president does a great job of describing our mission. It's very simple. It's 2 words: transforming lives, right? And so dropping off small donations and leaving doesn't necessarily transform lives. We want intimate partnerships. So when you go back to your companies, and these companies are saying, how can we invest in the institution? How can we invest in communities that have been historically and systemically underserved? This is a way that we can leverage the resources to make meaningful impacts, either at the individual level or at the corporate level, by contributing to our Roar Against Prostate Cancer funding program. I won't go over all of the particular levels, but we do once again have 2 different donor levels in terms of individual levels and corporate levels. The individual levels start as small as $50 and can go all the way up to $1,000 and more. The corporate levels start at $1,000 and can go all the way up to $10,000. And this is for us to truly impact lives, because one of the worst things that I remember, my friend who, as you can imagine, was very grief-stricken at his uncle who lost his life. And again, his uncle was very young. He was in his mid-40s. And one of the things that was just so regrettable is how it could have been avoided, right? It could have been avoided if we had that awareness and the advocacy for that awareness as well. And so with this particular campaign, that is what we want to do. We want to ensure that our communities, our Black men, old, young, and different, we want to make sure that they have the appropriate awareness so that they can make that change, so that they can get the treatment or they can get the screening that they need, so that they can be around much longer than they would be had they not been screened, and if they're not aware of what this particular disease can do. So I hope you all are having a great conference. Again, I'm glad that I was able to come and learn a lot from you all and share a little bit about what I know as well. If this is your first time on campus, I encourage you to spend a little bit of time going around. If this is not your first time on campus, welcome back. Again, my name is Dakota Doman. I serve as the Chief of Staff. And please, please, please consider individually or at the corporate level. Again, don't tell me your values, show me your budget, and I'll tell you what you value. And so if you value the health of our Black men, then you will strongly consider and advocating either personally or corporate within this particular fund so that we can increase that awareness that needs to be. Thank you so much for your time. Great job to the organizers of the event. Have a great day.
All right, moving right along, I'd like to call up Professor Melancon, please.
We're gonna do a short scene from a play I wrote called The Matter of Manhood. It's a prostate awareness drama. Hope you enjoy it.
I got a lot of things on my mind right now. Okay?
I understand that. You don't understand what I have on my mind.
I have an attorney too. They can get their attorney all day long. I have attorneys.
Can you just stop and listen to me?
Are you really listening to me? I spent 15 years building. And I would not allow some big downtown realtors to come and bogart me. Hell no. Maybe that was my mistake. Maybe I should have met a massage therapist.
Is that supposed to be humor?
I guess not.
But
Wait, what are you talking about?
all Tim,
Whoa, my brother Omar? Why are you talking to my brother?
because I wanted to know the truth.
Oh, so you have to talk to my brother about the truth.
You said your father had prostate cancer. You lied to me, Joe. Huh? We've been dating for 10 years now. We promised that we would always.
Listen,
honest
because
with each
it's
other.
all in the past now.
No, it's not. It's not. It's present. It's here. Prostate cancer is now.
Omar said, right? Omar said. Like Omar?
He said your father didn't like going to the doctor.
Oh, so he's the only black man in the world who doesn't like to go to see the doctor, huh?
And he complained occasionally of having body aches from time to time.
Yeah, it's body ache, but listen. Do you love me? Do you love me?
Come on. Yes, I love you. Of course I love you. That's why you are going to the doctor. You're gonna get examined and you're gonna get your PSA test.
Oh, no. I'm not doing no digital rectal exam. Do you know what they do to you? I'm a man, sweet cake, a man.
I know. And so was your father. And the doctor scheduled him for a digital rectal exam. They found a lump. The doctor wanted to do additional screenings to be sure of what it was. And did you even encourage your father to follow up with the doctor?
No, I didn't.
Okay. Why?
I didn't. Look, why are you doing this to me?
15 years. You remained living with your father.
And yeah, while Omar was in Paris trying to earn a living as an underrated jazz musician. Yeah.
You never encouraged him to see it out.
Do you know, let me tell you something. Do you know that some black African-American men, slaves, had their manhood violated? Do I need to describe it to you?
No, I know what happened to him. I'll tell you what else I know. I know that you are a 59-year-old man who haven't had a physical exam in 10 years. I know that prostate cancer may not have any notable symptoms, and that sometimes the symptoms may not even be discovered until the cancer is well advanced. Look. Some of the symptoms may even include regular urination. Oh, and symptoms may be frequent urination,
Omar.
especially at night.
Yeah, this is Joe.
Oh, and difficulty having an erection or even painful urination.
Why did you tell Sweet Cake about
Put the phone down.
our father? Hey, took care of him. You didn't.
And frequent pain or stiffness in the lower back, hips, or upper thighs.
Are you trying to take sweet tea from me?
Have the highest incidence of prostate cancer in the world. Overall, Black men are 1.7 times more likely to be diagnosed with prostate cancer and 2.1 times more likely to die from it.
That's enough, sweet cake. You'll find yourself a single Black.
So, you are a good man. I think you got this all backwards. You will find yourself another single Black man who lost a single intelligent Black woman who simply wanted you to take care of your health. Get your recommended prostate tests and exams. To want to stay healthy, Joe.
Sweet cake. Sweet cake. I'll go. It's a matter.
Thank you very much. That was very insightful, very entertaining. And for a minute there, I really thought that we had two people in the audience about to fight. I was like, security. Amazing acting. I loved it. Thank you so much for that.
I say this, the reason I want, this is a part of psychodrama. This is what I don't like to say it for play. I like to present it so that it becomes reality. I had to calm the people in the hallway. They were trying to figure out what was going on. Thank you very much.
Okay, so while we quickly get the table set up for our next panel discussion, I would like to start calling up our next panelists. Okay. Yes, all right. So if I could have Dr. Hill come up, please. Dr. Arthur. Pastor Mitchell. Unfortunately, Mr. Mitchell could not make it, Pastor Mitchell. And then we have Mr. Cornelius come up, please. Thank you so much. We'll begin.
So good afternoon, everyone. Want to welcome, I think we have one other panelist that's actually on Zoom, so we'll let them, I guess, set him up while we're doing that. My name is Rodney Hunter. I'm a Texas Southern alumni, also 2007 College of Pharmacy and Health Sciences. Very honored to be here, and I'm thankful. And I'm with some warriors, so it goes full circle to be here with you guys. I'd wear the outfits y'all have on also. So I'm glad to see that as well, man. So let's so do we have a Warrior Hill set up? You want to give me okay.
Hello, can you hear Warrior Hill?
Warrior Hill, good afternoon to you. Good afternoon to you.
Afternoon to you. I hope you can hear me, sir.
We can hear you fine. I just wanted to introduce you. Mr. Charlie Hill is a prostate cancer warrior, and he's also the co-founder of the Hampton Roads Prostate Health Forum. We also have here today in person Mr. Christopher Arthur, who's a Houston resident and also a prostate cancer warrior. And we also have Mr. Keith Cornelius, who's a prostate cancer support system and a community advisory board member here with our aggressive prostate cancer study at Texas Southern University. So we'll go ahead and get to it. I'll go to Mr. Arthur. As a prostate cancer warrior, what did the prostate cancer diagnosis mean to you?
Initially, it was shocking and wasn't a good thing because I come from I guess a segregated era where you didn't go to the doctor. And when you hear things that you have no control over, especially like cancer, you have no knowledge of it, you think of death. You don't think of there's life after this as well. At the same time, I'm a believer, if you're here, you can do something about it. So I've been having prostate issues. I had been having it since in my 50s. My biggest problem is it took so long till I was almost I'm in my 70s now. I was in my 60s before it was diagnosed as cancer. All these issues I've had, I constantly went to the doctor. I've had a TURP, which is a shaving down of the prostate. I've had frequent urination. I've had all kind of symptoms, but it only came out when I got a biopsy. So I didn't know what questions to ask, as well as my doctor didn't look like me. So it's a lot of things that we go through. So it was shocking initially as far as the diagnosis, but I got over that. By the time I was diagnosed, it was outside my prostate already. So it was a lot of things I couldn't have done.
Thank you, Mr. Arthur. Warrior Hill, I would like to pose the same question to you, like being diagnosed with prostate cancer. What did the diagnosis mean to you?
Thank you. Now, before I speak to that point, I'd like to just thank all of you who are participating in this program, who put it together, especially Ms. Ajewole and my friend, Dr. Penn Marshall. Thank you all. Let me just tell you what that diagnosis actually meant. I was diagnosed 2 weeks after I buried my first wife who had died from lung cancer. And I was still numb. I didn't have any prostate cancer issues, and now it gives me an opportunity to say early stage prostate cancer does not have any symptoms. I did not have any symptoms. I had scores that were incredible, PSA numbers of less than 2.5 in normal digital rectal exams. So when the doctors told me that I had prostate cancer, I challenged it. I had three opinions before I finally accepted it. So what it meant to me, it was confusion. I had 3 young daughters who just lost their mother, and they were asking me, are you going to die next? So it was a significant change in my life. However, it has turned into a very positive change because what I began to do was get answers to questions that I needed in order to make a decision about my situation. And I'm very pleased to tell everybody there, this year, I'm celebrating having been diagnosed with prostate cancer 20 years. 20 years I'm celebrating in June of this year.
Thank you so much, Warrior Hill. Mr. Arthur, I wanted to ask you, how did you go through your process of selecting the treatment that you were going to do for your prostate cancer?
In selecting a treatment, they gave me actually only two options, radiation or removal. If I had chosen radiation, then they could no longer remove it. So that wasn't an option for me, just remove it. Even though it's outside my prostate already, so it could have spread it further. So I had it removed, and for 3 years, it's undetectable. So far, so good. But you know, I didn't really have an option on what I should do, because radiation may or may not have worked. If it hadn't have worked, then I could not have had it removed at all. So it was just cut and dry. I wanted to live. It's sort of like that skit that the man talked about people's men. Men don't really discuss stuff with men as far as personal stuff, because they think they're manhood. We want to talk about that invasive rectal exam, because that's what men hate mostly about it. But you know, as the study goes, as I learned, that's the only way you can tell supposedly if it's swollen or not. But my theory was, if you could do a mammogram of a baby, maybe I don't know nothing about medicine, you should be able to do the same thing about a prostate as far as enlargement, but we're not there yet. But my treatment didn't have an option, so I just elected to have it removed. Like I said, so far so good. But you have to understand, there's a lot of other issues after all of that, after removal, after seeing that you have no prostate cancer at all. There are other things that goes with that. Ask your doctor question after question, research stuff.
Thank you. Thank you. Mr. Keith Cornelius, I actually want to shift to you. Me and you talked very briefly as we were watching that play in reference to the fear associated with African-American men being given that information and not even wanting that information. I wanted to explore that in reference to your experience in helping loved ones go through the journey of being diagnosed with prostate cancer, and what were the fears and uncertainties that you've personally experienced?
Well, I'm a member of a fraternal organization, and we've had several conversations privately and in a larger group setting with regard to men's health issues. And we talk about everything. We talk about sleep apnea, we talk about diabetes, hypertension. We rarely talk about prostate cancer globally. And I saw a slide that was put up. Cancer was the number 2 cause of death. Diabetes and hypertension was further down on the list. But there are lots of commercials and information about, you know, high blood pressure and diabetes. Don't eat that pork, stay away from that salt and sugar. And we understand that, but there's not a lot of conversation about prostate. There are 3 things that define a man, or as I understand it to be, and as it's been told in my life. First and foremost, your confidence and your ego. Secondly, your ability to make money and work and be a productive member of society. And probably the most important that we don't talk about, but it's always out there, your ability to have your ability to procreate and enjoy pleasure with a woman, or however you define that. And the prostate journey is a fear for men, because first and foremost, that digital exam, nobody wants to get that exam. And women really don't understand that. You say you do, and I appreciate the female journey. Even my wife last night, when I was talking to her about coming to do this presentation, and I was telling her about what was going on, and she said, well, women, we have, you know, that, speculum and, you know, the exams that you have, right? Pelvic exam. And you teach that to your young girls, to your daughters. Nobody teaches a young man or man about the digital rectal exam. We joke about it. And my own experience and the men that I, you know, speak to, the first time I went to the doctor, hey, Keith, you need to have, you know, your prostate exam. Okay, I got the PSA, no problem, doc. And he said, well, you need to get the exam. Okay, so I go to a urologist. Exam's going swimmingly. Okay, now it's time for the prostate exam. Okay, fine. just shoot me in the arm. No. So he starts greasing up and putting on gloves. Yo, man, what we about to do here? Well, I need you to pull your pants down, bend over, and we're gonna do the exam. It's not gonna take long. Oh, no, we're not doing that. This is we're not doing. I thought you just need to take a shot. No, this is how we do it. I need to feel. No, man, you're not feeling anything. I'm sorry, I'm out of here. I left. I literally left. And it took me a couple of months to go back and get that. Why and how did I go back? I spoke to other men in my tribe, in my village. That's how we did it. Also, you talk to young women early when they start menstruating. It's an educational piece. We don't do that with men because when this comes up, we're in our 30s and 40s, and our biggest concern is making money, enjoying pleasure, and our self-esteem and ego. That cuts right to that, and that stops us from getting the exam that we so sorely need. And that's what we need to do to correct it. There needs to be a village of men like there's a village of women. There's a sisters network. There's no brothers network. NFL wears pink during October for breast cancer awareness. NFL, all sports leagues, they don't say a thing about prostate cancer. That's where it needs to start. And that's how the fear is going to go away when we bring more grown men who share their experiences, and we get over that huge hump of the prostate, the digital prostate exam, because it is a matter of manhood, but it's not the manhood that people want to give us credit for experiencing. It really does cut to who we are as men.
Thank you, Mr. Cornelius. Warrior Hill, I wanted to shift back to you in reference to the cancer-related treatments you received, as well as the healthcare delivery. What stuck with you the most? What stays with you to this day about those experiences?
Well, actually, 20 years ago, there weren't that many fancy procedures being practiced. So I had what is called the male version of a C-section, open prostatectomy. And one of the things that was extremely important to me was that even with the open surgery, that I not lose my sexual function. So what we did was to learn about something called nerve-sparing prostatectomy that was only done at that time at Johns Hopkins. And I went there for that reason only. And we had an open surgery, and my sexual function was protected. To the gentleman who've just spoken, most men don't know about these things. I did a lot of homework. Remember, I had lost a wife, and they kept telling me she wasn't treated early enough to be successful. So I started doing my homework 20 years ago, and I learned all I could do. And when I got to the point that for my actual situation, I had some answers to get me from where I was to where I wanted to be. The other part of that process is that when I ran into some difficulties with incontinence, well, there are some solutions for incontinence, and there are solutions for erectile dysfunction. Most men typically don't know about those either, and they've been present for quite some time. So it is important that we know about all of those solutions to these problems, and they're not that difficult to understand. The gentleman just mentioned something that's extremely important, and that is men in general don't talk about some of these things because nobody wants to own the fact that they have that problem. When that issue is resolved, then you can have more conversation. The reference was made to the group we established here in Hampton Roads, Virginia. The reason we've been doing what we do is that we had to address the issue of awareness. And we do awareness fairly well. There's nothing that we do in prostate cancer awareness that doesn't address the things that are important. And all of our gatherings, all of our meetings include women. We will not have a gathering of men unless there are women present. And we got over that hump. Took us 2 or 3 years to get over that hump. But you know, the resistance was not coming from the women. The resistance was coming from the brothers who, no, we can't have any women in this. Well, I said, well, then we're not going to do anything at your church or your organization or your fraternity. So awareness was the top word, and making sure everybody knows what can be done.
Thank you, Warrior Hill. Mr. Arthur, I'm now coming back to you. When it comes to maximizing health-related outcomes, what is some insight you would give like African-American men in general about support systems to bring things to the forefront? Like, how can we do better about that?
Well, I had a support system from my family, my wife mostly, and we're a praying family. So it's like, sometimes you have to make choices that you don't particularly like that you choose. But as far as, like you said, the functions of a man, life or function, which one would you take? You know, I take life because there's other things that you can do. And if you have the right support system, my children were saddened when they found out. They're all grown. I have boys. I want them to be aware of what can happen if it's not detected. Don't wait like I did or like my doctor did. I'm so glad to see Dr. Jones here. I don't see any of my urologists here, or any of them that look like my urologists here. But you have to have a support system. I had some ministers at my church prayed for me. We prayed together. I was okay. It's always, in my opinion, victory after this, you know, and there are things that you can do for other things that happen after this. And I'm still going through stuff. I'm dealing with it okay. And I have no problem talking about it. There are solutions to every problem that comes up after removal of prostate. If you suffer with erectile dysfunction or incontinence, there are things for that. Everything can be worked out. You know, hands this in and just handle it. I want to live a long, productive life. I want to be able to give back to my community. I want to be able to save as many young Black men as I can with the knowledge that I have in reference to prostate cancer.
Thank you, Mr. Arthur. And Mr. Cornelius, same question I want to pose to you as we come to a close. Like, what is some insight you can give young African-American men in reference to the support systems and bringing things to the forefront of their mind when we think about health-related, really optimizing what we're trying to do here in general?
Education. Education can be good and it can be bad in terms of this particular disease. Good in terms of you need to find a doctor that you trust, a credible, good doctor that you're going to rock with for a while, not somebody that you're in and out of because of your health plan, but somebody that you can speak openly and honestly about all of your male issues. So that's first and foremost. The other thing that can be difficult about education is that there are many different varied treatments from what I understand and talking with you know, my village and my doctor about how to treat prostate cancer, all different kinds of treatments. And what they don't tell you, which scares a bunch of men, how it interacts with the urethra and what needs to happen. And they don't tell you that there is shrinkage there afterwards. And so shrinkage, along with incontinence, along with erectile dysfunction, they're not things that most men want to discuss. And so we need to get over that. So there needs to be continued education, and we need to press through the embarrassment, the shame. We need to link with our women, and there needs to be a male network to deal with these issues. And we need to start early talking to our young men, talking to them about some of the things that may occur. I sit here today. I am a regular physical exam guy, have all of my tests and numbers, but I can't tell you that right now I don't have prostate cancer, that it's not growing in my body. I don't think that it is. I feel real good, but that's one of the fears. That's one of the problems. So education, continually getting checked out with a good doctor that you're going to be with for a while. The doctor that I've been with him for over 20 years, and we joke that one of us is going to bury the other. He has the names and numbers of all of the important people in my life in case something comes up with me, and my wife and my children have his number in case something comes up. So, you know, again, it is all about education. It is all about getting checked out. It is all about pushing through that fear and getting regularly scheduled checkups from A to Z.
Thank you, Mr. Cornelius. I want to take this time to thank Warrior Hill, Mr. Arthur, Mr. Cornelius. It's been an honor to to moderate this panel. And thank you for the opportunity, Dr. Ajewole. Y'all have a great afternoon.
Thank you very much for your authentic discussion. Appreciate it. Okay, so next, we're going to call up our next panelist for the call of action, the call to action. So if I could have Junie Simpson come up, please. Mr. Aaron, Junie Simpson. Oh, thank you. Did I say your first name right? I did. Awesome. Thank you. And then if I could have Mr. Aaron Aware. Thank you. Dr. Milton. Thank you. And the facilitator, Dr. Masavin. All right. Thank you so much.
Well, ladies and gentlemen, good afternoon. My name is Rashid Masavin. I am the Dean of College of Pharmacy and Health Sciences here at Texas Southern University. I've had the honor and the privilege to serve as the Dean for the past 3 years and a few months. So I want to welcome you to our campus. I want to thank our organizers of this event that is so absolutely important. I want to acknowledge Dr. Veronica Ajewole for all of her efforts in this area and for inviting me. So a few comments before we start. And once again, I find myself between you and lunch. So we gotta hurry this up. That happens to me once in a while in meetings. So first of all, I apologize if I'm not completely formally in suit and tie. I have to go to, shortly after this, I gotta go to the TSU football game. Then I'm going to have to change shirts and go watch the Astros win the World Series. So that's the reason for the attire. I want to start off before we move on to our panel with a couple of introductory comments. And one is, as you all know, and I have articulated since I've been here, that universities have a commitment and a responsibility to the communities in which they serve. And I think a great example of that commitment and responsibility is what's happening here today. So Dr. Ajewole, you, your group, all the organizers, that is a true example of how this university is showing its commitment to this community in which it serves. So a couple of other quick things. One is, many years ago when I was doing my postdoctoral training at University of Michigan, my lab ended up being right next to the laboratory of Dr. Francis Collins, who just recently left NIH as its director. He was director of NIH, as many of you know, and he has a famous quote I want to share with you, and that is, he says, genes load the gun. Your genes load the gun. Your behavior pulls the trigger. So, and as I begin to ask the panel to tell us a little bit more about call to action, I want to bring those to your attention, dear panelists. One, again, is the quote of Dr. Francis Collins, again, genes, load the gun, your genes, your behavior pulls the trigger. The second thing I want the panelists to be thinking about as they introduce themselves and talk to us about what we need to do for call to action is that we all know that in the United States, we actually don't have a health care system. We have a sick care system. So keep that point also in mind, that it's not truly a health care, but a sick care. And as you also well know, it just so happens that if you're privileged and have the job and this and that, you obviously have access. Otherwise, you don't. So access is an issue. And the last item I want to talk about, and that's why I think it's so great to finish with a call to action, is I don't want to fall into that expression that says after it's all said and done, there is more said than done. So we need to do more. So with that, I would like to ask the panelists, we can start with you, Joni Simpson. Let's start with you, please. So if you maybe want to quickly introduce yourself, and I think according to the program, everybody has about 2 or 3 minutes. Remember, we're between them and lunch. Keep that in mind. But again, this is a very important topic to wrap up as far as what do we need to do to bring awareness. So Ms. Simpson, please go ahead.
Hello, everyone. I really truly appreciate the opportunity to speak here today for a few reasons. I work for a company called Genentech, Roche. We are a drug manufacturer. A few years ago, we changed our operating model to do what we call bring healthcare local to ecosystems. I live in Pearland. I get my medical care from the Houston Medical Center. And this city is near and dear to my heart. And we know that healthcare is broken. And this model and the company I work for presented an opportunity for me to work in my city and for an opportunity to be part of that solution and fixing it. And there are a few ways that we're doing that at Genentech. I brought some slides, but I think I'm just going to talk. That's okay. Yes, because I hope I'll be back. And so that is my inspiration. Also, we know I have no disclosures because I'm here representing Genentech as a full-time employee. So I wanted to say that. But the changing of the model and bringing healthcare local to what we call ecosystem really forced the field teams that support the community to look at the individual and unique barriers that patients face. And we changed the model around 2020, where when all of the social unrest and health inequities was highlighted thanks to the pandemic. We know that thought leaders like yourself has dedicated your entire life's work with marginal progress in terms of closing gaps in care. And my company actually markets over 40 drugs in 7 therapeutic areas, and oncology is a huge focus for us. We are working towards a statistic that by 2045, we will be a majority minority country. Several states are already there, and we know we play in a lot of disease areas where these disparities exist. So we feel we have a scientific obligation to, first of all, really diversify our clinical trials so that they are representative of the patients with that disease. Secondly, we want to make sure that all patients, regardless of what you look like, where you live, how much money you make, that you have equitable access to the innovative medicines that is driving our advancements in science. And so we are here and we want to be known as a trusted partner in the community. Several ways that we're doing that are with our screening campaigns and educational awareness. We feel that that is key. We're making sure that all of our materials are meant to activate underserved and marginalized patients so that they can answer that call to action to seek screening. I am here today representing our company, but I'm also here as a woman that sits at an intersection. I'm a Black woman. I'm an immigrant from Jamaica. I am a mother. I'm a single mother, and I care, and I have a son. And a lot of the things that I hear today, and by the way, my son is an actual graduate student at the Texas Southern University, and he's also on the men's basketball team here at Texas Southern University. Carl Nicholas, number 5. And so being here to me is very near and dear to me, but I was talking with my colleague and she shared with me that I need to talk to my son because that lived experience that was just shared today, that's real. That play that was just enacted, that's a real situation in homes. And we have an obligation as Black women to really undergird our Black men to seek care.
Thank you. Thank you so much, Ms. Simpson. Let me move on to Mr. Aaron Ewer. I hope I say your last name correctly. And you are a practitioner, so if you could talk to us about our call to action and the awareness we need to create.
My name is Aaron Ajewole. I also immigrated to this country some 40 years ago. I lived through some of the experiences of being a minority. Despite my previous education, I had to start from the scratch. I flipped the hamburger, I want to say that. So I don't want you to just look at my tie or my suit and feel like it's been like that. No. I'm into primary care practice. And first, I want to thank the organizers of this program today. I want to also say that it's quite a source of information, education, and empowerment to me to be here today. I've gained a lot of enthusiasm regarding what I need to do about prostate cancer or prostate screening, beginning from just now. I chose to work from our clinic that's laid out in a commercial center as distant from a 3-story building. The implication of this is to make my service available to people I consider to be affected by some of the social determinants of health that we have all discussed here today. It's been a great source of inspiration for me to do what I had to do all these years. But one thing is certain, all my clients are not like Mr. Kate Cornelius. Could you stand up for recognition, sir? He made a very, can we give him a round of applause? The reason I did that is just to cut my story short. He already stated the fight he had with his, probably at the beginning of his primary care with relating to prostate cancer. This is what we go through every day. And I want to also say quickly that my clients don't dress and speak like Mr. Kit Cornelius. What this implies is that every day I'm faced with more difficult clients who may not understand anything or ready to accept what they're being told. The implication is very serious. I'm into primary care, meaning I'm very diverse. I go into hypertension, we deal with all that. Diabetes, these are other problems, weight, that are very common. And I also into STDs. Once you mention the idea, first of all, a lot of clinics and even the city of Houston does not swab the mouth or oral swabbing. Talk less of rectal for MSMs. So to them, it's not part of the game. So they come into my clinic and I'm confronting them. When was the last time you were swabbed? Do you do this? Do you do this? Okay, that means there's some concern here. Then for rectal, oh, no. Come on, man. It takes a lot. What am I driving at? We all need to be on deck as far, all hands have to be on deck as far as prostate screening is concerned, because it takes a lot of education to get our clients to kind of listen at all. I have had to threaten, I have had to turn into a drama performer right there in the clinic, what could happen. And I have had to really do you want me to show you examples of people, bring the record to you to show you that it is real, that some men could have, MSM could have gonorrhea chlamydia infection and never know it, to the point they will have a fistula and actually be leaking, having two anus. And the fight goes on and on and on and on. And I do point out that not so many clinics will afford this, so you may think it's not part of the deal. It is. That brings me back quickly to prostate screening. For most men, it's when you talk about DRE, the digital rectal exam, it's a no, don't even go there. But I feel very empowered today that I'm beginning to see a new line of approach to this. And on behalf of the clinic that I work for, that is Be Busy Wellness Clinic. It is a federally qualified clinic, and I will bring this to bear on the organization seriously, that we have to approach this, prostate screening in a different, with the same intensity we do with STDs. And I also want to mention that even though I've not had the empowerment from our CEO to make any commitment on their behalf, I know they will. And at the same time, I do understand that we're going to be having some screening, including prostate and other issues like diabetes and hypertension, coming Saturday at our location at 8785 West Belfort. So please bring your families, bring your friends. It's a good place to start the whole process. Thank you.
Thank you, sir. Thank you. Thank you, Mr. Ewer. So this is very interesting. So you heard first from Ms. Simpson on the role that pharmaceutical companies play in this particular disease. And then we heard from you, Mr. Ewer, on the clinician's perspective. And to conclude this discussion, I want to go to Dr. Milton, who is here with us at TSU to tell us about our role, what it is that we do here as educators, as a university. Dr. Milton.
Can you hear me? Okay. I'd like to thank the committee and just allow me to be a part of this, because this is near and dear to my heart, because my dad, was diagnosed with prostate cancer years ago and got the surgery. So everything that the gentleman was talking about, I understood, but I also understood it from a family aspect. Because when you hear the word cancer, you automatically think death. Without the education, we know that's not the case. So my father had the surgery just like you did, Mr. Arthur. And then he was great for some years and later was diagnosed with lung cancer. And on March 10th, 2018, I lost my best friend. So for me, this is very personal as well as professional, because it's important, very, very important that we get the word out. I, like Dr. Lau, social work background. So I spent a lot of time in the field working with disadvantaged people, families, different cultures, and cancer was prevalent in a lot of those situations. Trying to figure out what exactly resources that they can receive to even possibly get the treatment that they need. In social work, we deal a lot with the theoretical perspective. And one that we constantly use is the systems perspective. So we're not just looking at cancer, we're looking at all the other things that cause or play a role in cancer. So we already know in society today, unemployment is a huge issue. And keep in mind, we're focusing on Black males. So incarceration rate, healthcare, just being able to transition through society because there's so many barriers. And if we bring up the term of masculinity, that's huge. We're fighting that fight and we'll continue to have to fight that fight. I was raised off the mantra, you better not cry. And guess what? That mantra is still being used today. Masculinity, it's all about having the money, the clothes, girls. That's what makes a man. So they think. Being responsible is what makes a man. Going to get tested is what makes a man. But once again, we're fighting that fight of chipping away at masculinity. So how do we do that? It's going to be a tough fight, but it can be done. We started the fight today. All of you sitting in here is a part of the fight. We have to continue to fight. It's not going to be easy. Who wants to feel like they're less than a man? I don't want to. And based in some of our minds, digital rectum exam, that makes you less than a man. Talking about your issues, erectile dysfunction, that makes you less than a man. Having issues, period, makes you less than a man. You're supposed to be the provider for the family and get the big piece of chicken right on Sundays, right? It's okay to cry. It's okay if you don't get the big piece of chicken. But we have to push education. Some of us don't even know what prostate cancer truly entails because we just listening to what we heard other people say. Because we're afraid to go hear the real information because, Lord forbid, I have prostate cancer. We have to push the envelope. So how do we push the envelope? We meet them. We had a saying in social work, we meet the client where they are. So where are the brothers located? You're in church, right? We got to go to the church and educate. Where are the brothers at? They're in the barbershop, right? We got to go to the barbershop and educate. Any way that we can disseminate the information, we have to get it done. I think I got the eagle eye over there at me. I know it's lunchtime, so I'm just going to shut it down.
Thank you, Dr. Milton. So and thank you all. As I listen to the three of you with your different perspectives, it seems to me that at the foundation of this fight, which we all know is multifactorial, but at the foundation is education from all of your perspectives, even though you're in very different types of settings. And then next is screening. And of course, as you all know, screening comes with access. So once you're educated, then we need to make sure those folks have access to be able to be screened. So, and I believe, if I'm not mistaken, Dr. Ajewole, there was going to be a slide with some bullet points of some of the other factors that we should pay attention to when it comes to call to action. But again, just listening to our wonderful panelists, it is very clear that foundationally, we need to educate. Education leads to, there you go, education leads to screening, assuming and hoping that all of those who are now well-educated and understand the disease have access to be screened. And of course, the next step is treatment, certainly. So with that, I want to, again, thank you, our panelists, Ms. Simpson, Mr. Ewert, Dr. Milton. Thank you so much for being here. Really appreciate you. Thank you all.
Okay, guys, we are almost done. Thank you so much for your patience. So the last thing I'm going to do is call Ms. Azib Yusuf again. Back to the podium, please, real quickly.
Like I said, Dr. Ajewole is going to make me lose weight so fast. Thank you. Lunch is going to be ready. But before we talk about lunch, I really wanted to say thank you to James from Precinct 1, Commissioner Rodney Elliott's office for being here, for being so patient, waiting for us. I now have some good news from our community partner. My dear friend, Dr. Amjad, I thank you for being here. Not only you are here, you're proposing to provide 1,000 PSA testing at no cost to the patients. Thank you. With that being said, Dr. Ajewole, our leader, we can't do the work without your support and dedication. You mean so much to us. We are new, but I am a graduate of Texas Southern University. This is the area where I took many of my classes, and I have learned so much, and to learn more from you, and thank you. Now I present you James from Commissioner's office, please. Thank you.
So I'm standing between y'all and lunch. So I'm a firm believer in the 3 Bs, which is be brief, be brilliant, be gone. And so I definitely plan to be gone. But my name is James Burnett. I'm a community engagement coordinator in the office of your Harris County Commissioner, Rodney Ellis. And we're just here to say thank you for the work that you're doing here. This is a very important topic. And as a young Black man watching, participating in this, it's good to get this information. I definitely plan on getting screened when I turn 35 for the Dr. Bowman. I'll be remiss if I'm in a building named after Barbara Jordan and Mickey Leland and not implore you, if you haven't already, to exercise that fundamental right to vote on Tuesday. This is a consequential election, and I'm not going to tell you who to vote for, but this election is too important to let that pass you by. So I encourage you to vote on Tuesday. But more importantly, I came here today just to present this certificate of recognition to the Texas Southern University College of Pharmacy and Health Science in recognition of collectively addressing prostate cancer disparity within the African American community. Precinct 1 applauds your focus on education around health equity. So Dr. Yusuf or anybody who wants to come out, would love to present this to you.
I appreciate you. Thank you. All right. Thank you again to the audience, to those that have stayed through with us online, and to the audience that have stayed in person. We are very grateful. I do apologize. I know we are like 34 minutes over, but I have 2 very important videos from our funding agencies. Please permit me to share those videos. We have videos from CMS that funded this grant, as well as from ASSER, explaining that the great works that we've done will be continued into the future. These videos are about 3 minutes long, so please permit me to do that. Thank you.
Hello, conference attendees and distinguished guests. I am Sean Trotter, Public Health Advisor and Program Officer, sharing on behalf of the Center for Medicare and Medicaid Services Office of Minority Health team and my fellow Program Officer, Brian Young, for the Minority Research Grant Program. I want to start by saying how our deliberate efforts to review and address this topic will be met by members of the African American prostate cancer advocacy community with great appreciation and excitement. There have been significant advances in the understanding and treatment of prostate cancer over the last century. Despite the many important discoveries and treatments developed for African American men, there are still unmet clinical research opportunities, lack of access to high quality care, data discrepancies, and general coverage concerns that many are seeking to remedy. In 2020, when Doctors Veronica Ajewole, Uche Ndefo, and Grace Loud were awarded funding for their project entitled Development of Predictive Model and Social Determinant of Health-Based Interventions for Aggressive Prostate Cancer Among African American Males, our expert review committee immediately saw an alignment with our intention to better meet the healthcare needs of medically underserved populations and awarded funding. Today, in what face-to-face Shoulder to Shoulder, Let's Talk About Prostate Cancer represents is dynamic research and strategic dissemination. Key to our success is disrupting the drivers of health disparities and a vibrant communication platform that reaches those ready for action. Face-to-face and shoulder-to-shoulder is paramount in our united fight to eradicate prostate cancer. In our attempt to uncover the underlying drivers that may contribute to and produce unequal protections and access for African American men, this research is an opportunity to reimagine the role of researchers and community partners to address these challenges, for which CMS OMH can support investigators on interrelated interventions that may be needed, such as center inequity, support targeted strategies that address systemic inequities to achieve universal goals, and embed equity principles within internal processes. Elevating a whole community narrative, telling more complete story of the African American male by recognizing our unique strengths and challenges and elevating voices by us traditionally left out of the main narrative, incorporating the principles of the right of all individuals to be protected from neglect and harm, charting a pathway of change, illuminate what is possible, and shift public will towards joint action. And finally, aligning agencies and sectors. Collaborate more effectively across sectors towards shared prosperity, addressing systemic problems in the African American prostate cancer survivor community. Our collective effort today in face-to-face, shoulder-to-shoulder should achieve baseline understanding of a prostate cancer advancement, develop a common understanding, and have all attendees feel equipped and confident to describe and discuss the state of African American men's health at a high level. Again, it is an honor to welcome you here today and just a privilege just to see all of you in attendance on this virtual webinar. And I want to continue to express CMS OMH's continued support and praise of our Minority Research Grant Program awardees for their outstanding contribution to the scientific enterprise. Thank you, and enjoy today's conference.
Thank you very much. That's the message from CMS, the funding agency, and we have one more from ASER. Thank you.
Hello, participants, presenters, partners, and friends. On behalf of the Acting Regional Administrator for the Health Resources and Services Administration's Office of Intergovernmental and External Affairs for Region 6, Commander Cheryl Trail, I would like to say thank you for inviting us to this conference. My name is Stephen Richards, and I am a public health analyst with HRSA IEA Region 6, based out of Dallas, Texas, and I am our office's state lead for Texas. HRSA IEA's mission is to provide on-the-ground outreach to increase the reach, impact, and awareness of HRSA programs. In doing this work, I get to meet partners like Texas Southern University that are striving to make our communities stronger, healthier, happier, and more resilient. I've had the pleasure of meeting Dr. Veronica Ajewole in person at an event addressing Black maternal health disparities in Harris County. I've seen firsthand how TSU plays a part in bringing together community partners, faith and political leaders, researchers, clinicians, and others to better the health and well-being of the community across a variety of health topics. I know they have existing partnerships with HRSA-supported health centers in the Houston area. So it's unsurprising to me to see they have brought all of us together today to discuss the findings of the project titled Development of a Predictive Model and Social Determinants of Health-Based Interventions for Aggressive Prostate Cancer among African American Males, and to stimulate advocacy and education efforts for prostate cancer screening among African American men. Thank you, Dr. Ajewole, Dr. Ndefo, Dr. Loud, and all the others involved in this project and with this conference. It is great to be able to provide some remarks today. HRSA programs provide equitable healthcare to people who are geographically isolated and economically or medically vulnerable. This includes programs that deliver health services to people with HIV, pregnant people, mothers and their families, those with low incomes, residents of rural areas, American Indians and Alaska Natives, and those otherwise unable to access high-quality healthcare. HRSA programs also support health infrastructure, including through training of health professionals and distributing them to areas where they are needed most, providing financial support to healthcare providers, and advancing telehealth. In addition, HRSA oversees programs for providing discounts on prescription drugs to safety net providers and facilitating organ, bone marrow, and cord blood transplantation, among other programs and health topics. On September 23rd, 2022, the U.S. Department of Health and Human Services announced the awardees of the fiscal year 2022 Accelerating Cancer Screening Funding, which supports health centers to increase equitable access to cancer screening and referral for care and treatment by enhancing education, case management, outreach, and other enabling services in close partnership or coordination with National Cancer Institute designated cancer centers to deploy health specialists and patient navigators for populations served by health centers. HRSA, our partners, and our funding recipients are dedicated to addressing cancer screening and early detection to reduce the cancer death rate by at least 50% over the next 25 years and support families living with and surviving cancer. Therefore, we look forward to seeing what comes of this conference. And we were thankful that a fellow federal agency, the Centers for Medicare and Medicaid Services, provided the funding for this project addressing aggressive prostate cancer among African American men. Again, thank you for the invitation to participate, and thank you for all you do for our communities.
There are other screening options. So the main goal here is please have that discussion with your healthcare provider so we can identify what is best for each individual. Again, I want to say a big thank you to the online audience, to the in-person audience. Please, in your package, you have the booklet, all the QR codes, the call to action, the giving page, everything is in the booklet. If you've not had an opportunity to make any commitment, feel free to scan those. And I want to announce that we do have a box lunch is in the lobby. We have poster display and we have vendors in the lobby that you can interact with. Thank you again for joining us this afternoon. It's been our pleasure. Enjoy the rest of the day. Thank you very much.